A very good evening to all of the joinees, including the Program Director, Organizing Secretary, and Scientific Chairperson. I hope we are all here as of now. 2 more minutes to go. Am I audible?
Yes, ma'am, you're audible.
All right. So we have the Program Director, the Organizing Secretary, and the Scientific Chairperson with us, right?
Yeah, I'm Pathagat Das. I'm the scientific chairperson.
Hello, sir. Yes, sir. Very, very good evening. I saw that you're there. Just wanted to confirm so that.
That's fine. Thank you, Rumila.
Yeah. Thank you. So 2 more minutes to go. So it's already 5 o'clock. We have about 42 participants. Anita, do we wait for another 5 minutes to start? Am I audible?
Yes, you are audible.
Okay, thank you.
प्रशांत भाई नमस्कार.
नमस्कार नमस्कार.
Romila, good evening. So good to go.
Good evening, bhai. Good evening. Yeah, I think we should start. We have about 50 participants now, and gradually, I think we'll gather them up. Should we start?
So Dr. Suresh Babu has joined, and the.
Yeah, I was just concerned about that because after the quiz, this is the first session. I have asked Anita to inquire, and I think she was on it. She told me so. Yeah, he's here. Dr. Suresh Babu is very much here. And
Dr. Satya has joined.
Unmuted.
His master has joined.
Yeah, yes.
Good evening, sir.
Yes.
Good evening, Satya.
Dr. Satya has been there with us for quite a bit.
Okay.
Like I've seen him since another last 15-20 minutes. So.
And the great Ravi has also joined today.
Yeah, I know Ravi Bhai was also there right from the beginning when I joined.
So
Every day I'm there.
Romila, please start.
Yeah. So a very good evening to all of you. Welcome to the second day of the AIO webinar series, and we'll focus on lung today. So there's been a little change for some while. Our organizing secretary, Dr. Soumya, will join us shortly. And we have, with all my heart, I welcome our program director, Dr. M.V. Chandratan, our scientific chairperson, Dr. Tathagat Das sir. He has been there with us for long too for the day. I mean, like I saw him right from the time I've joined. So thank you so much. I would request Ghanshyam, I welcome to Ghanshyam, Dr. Ghanshyam Biswas as well. He'll be introducing and setting the context for the day. Over to you, Ghanshyam.
So thank you, Romila, and so thanks Chandrakant for joining again, and thanks Tathagat and Ravi for joining overseas. So at least so good friends of all SCBNs, even Prashant Bhai, all SCBNs have joined together. Actually, Somay has gone for his batch reunion, so he might try to join. So yesterday we had a beautiful 4 hours session on breast cancers. And if I talk about, so there are 184 participants, and the highest, even at 9:10 when it closed, so there were 125. And so we could finish 10 minutes late. So otherwise the time was maintained because Garima was there. And I expect the same from Dr. Romila. So
Yes.
and that's also, so this is all about lung cancer. And since Tathagat has been working in the lung cancer field, so I thought that so he must be there, and he also has invited one of his colleagues, surgeon colleagues, who will also speak on the subject. And so let's have a good scientific discussion. So I hand over to Dr. Romila for the first session, that is quiz.
Yeah, let us proceed. And that's always an interesting and a very active session. I would request Dr. Satya Sadhan Sarangi, medical oncologist from Lucknow, to kindly take up the quiz session.
So first of all, good evening to all, and thank you, Dr. Romila, and thank you to the organizing secretaries and the chairperson for giving me this opportunity. So myself, I'm Dr. Satya Sadhan Sarangi, currently working as assistant professor in the Department of Medical Oncology at SGPJMS Lucknow. And so the task that was given to me is the lung quiz, and I hope everyone is ready for the quiz competition.
So
I think so.
Those who have joined new, so this will be a 30-second. So Dr. Satya will have 5 questions. So 4 choices. So one of them will be a best choice, and you have to answer in the chat box. So our team members who are in the who are taking care of that, so they will jot down. So after a while, in between the sessions, we will announce the results.
Where is our prize? Where is our prize yesterday's?
So after the meeting is over. After the meeting is over.
No. That would
I joined only for quiz prize.
Okay. So we'll be seeing Dr. Ravi.
So there should be some attractions, no?
Online prize.
All right. So can we start? Sir, can you, Dr. Satya, are you being able to share your slides, or should I ask our team to?
Kindly ask your team to share the slides.
Anita, kindly please. Yeah.
Yes.
Yeah.
I hope the screen is visible.
Yeah, it's visible. Okay, so am I audible to all?
Yes,
Okay, so
very much audible.
Okay, so the first question for today's quiz is, which of the following is a indication for giving osimertinib in lung cancer? Option number A, for patients with completely resected epidermal growth factors, EGFR mutated stage 1B to 3A NSCLC. Option B, first line EGFR exon 19 deletion stage 4 lung cancer. Option C, post progression on erlotinib in a patient with T70M mutation. Or option D, all of the above. 6 seconds still remaining. And I see a lot of answers coming up. Okay, so time's up. I think we can move to the next question. Okay, so here on one side you will see the drugs,
Satya,
and the other side.
you have to inform the right answer, no? So then only.
Okay, so I thought.
So
okay,
if you
so
say the right answer, then the team members will just have the note then, no?
Okay. So the
Yeah.
right answer
Yes,
for the
yes, yes.
first question was
Give me
option
right
number D. That is all of the above. A, B, C, and
Yeah.
all the indications are for osimertinib. So I think we can move to the next question now, sir.
Yeah, you can.
So I think there is some issue with this options here. Uh, uh, is everyone
Oh.
able to see the options? Because
No, no.
on my screen it is I was seeing only square
Blank.
blocks only.
Yeah.
I think they are.
So yeah.
Okay. Okay. Now it's okay. So
Hmm.
on question number 2, you have to select the right combination for the drug and the their mechanism of action. So option it's afatinib, alectinib, entrectinib, and sulfatinib. You have to select the correct option that has all the correct combinations. Three more seconds left. Okay. So the correct option here is option number B. 1B, 2A, 3D, and 4C. Option number B is the correct answer for question number 2. So I think we can move to the next question. Okay. Question number 3. So all of you can see the pictures of two noblemen who has got the Nobel Prize for their extensive work in the immune regulation in cancer therapy. So you have to tell me in which year they have got the Nobel Prize. 2017, 2018, 2019, and 2020.
So before somebody can answer, I will just have a good news. So one of these, Dr. Allison, is coming to Bhubaneswar in January 2025 as a part of faculty for Immuno-Oncology Society meeting. So you'll have the Nobel laureate coming to Bhubaneswar on January 30th.
But will he play a
Great.
gig? Ask him to play music.
Okay.
Okay, so the time is up for question number 3, and the correct answer is B, that is in 2018. Okay, so next question, please. So it's basically a case-based question. A 70-year-old, otherwise former smoker who presented with cough and hemoptysis of 2 months duration has a 3 centimeter cavitating hilar mass, bilateral parenchymal lung nodules, and a 2 centimeter hypoechoic lesion in the hepatic lobe. Biopsy is consistent with squamous cell carcinoma. PDL1 TPS score is 40%. MRI brain is normal. So you have to tell me which of the following combination would be the best choice for this patient. Carbopacli with immuno, carbopemitrexate with immuno, carbopacli and bev, carbopemitrexate and bev. Okay. So the time is up. So the correct answer is option number A, carboplatin and paclitaxel plus immunotherapy. Next question, please. Okay, so this is the last question for today's quiz. Which month is considered as the lung cancer awareness month? March, June, September, or November? So this is the last chance to get any prize, guys. Five more seconds left. Okay, so time's up. And the correct answer is option number D, November. November month is considered as the lung cancer awareness month. Okay, thank you.
Thank you so much. Am I audible?
Yeah.
I'm sorry, there are certain glitches on my end. It will be fixed in a couple of minutes. So we will announce the announce a little later, and we'll proceed towards our first talk of the day, the Pacific Trial Updates by Dr. Suresh Babu, Medical Oncologist, Bangalore. Over to you, Dr. Suresh, sir.
Thank you, Kanesh.
Thank you.
Is my screen visible?
Oh, yes, sir. Your screen is visible, sir.
Thank you. So I'm going to talk to you regarding specific trial update. Just start with introduction and go with the trial update. So we know that the lung cancers, among which 85% are the non-small cell lung cancer, again among which 25 to 40% are locally advanced. Another very important thing is among which 30% locally advanced and resectable. So this is the group which is concerned for us, that they are unresectable and they are more likely to recur. If you see in a locally advanced lung cancer, stage 3B and 3C, invariably unresectable, go for the concurrent chemo RT or the palliative chemotherapy. Stage 3A, some are resectable, again, depends on the surgeon decision. One of the risks with stage 3A is that there could be a possibility of incomplete resection, that we may end again going for concurrent CTRT in such patients. So what decides the resectability? Again, experience of the surgeon, nodal status. So nodal status, if there are visible nodes, node more than 3 centimeter or so, unlikely that the patient will go for patients. We have to go for the concurrent. Another very important, having locally advanced disease, usually following a neoadjuvant chemotherapy doesn't seem to improve such population. So we have to decide upfront only whether the patient will go for surgery or concurrent chemotherapy. Decision has to be made very practically upfront. So treatment of lung cancer is always a multi-tumor board treatment. Surgeon, radiation oncologist, medical oncologist, everybody sitting together and evaluating the patient and deciding on the further treatment. Again, concurrent chemoradiation is given in very fit patients, and sequential chemotherapy will give in some of the patients who are not. In our country, depending on the fitness and nutrition, majority of the patients are going for chemoradiation. Some patients who are fit are receiving concurrent. Even with such treatment, what is the thing is that median progression-free survival is only about 8 to 12 months, and 5-year overall survival varies from 15 to 25%. So rest around 75 to 80% invariably die after 5 years, either with progression or with any other causes. So this is one of the concern for the stage 3 advanced lung cancer. What immuno-oncology has done in lung cancer is that the durvalumab, particularly if you give chemoradiation, it will lead to tumor antigen release. There will be upregulation of PD-L1, and PD-L1 overexpression leads to the immune cell activation, invasion, and T cell inhibition. What durvalumab does is it blocks the PD-L1 and restores the T cell function. Thereby, there is a reversal of immune suppression and leads to systemic anti-tumor response. This was the concept why durvalumab was used in the locally advanced lung cancer after concurrent CTRT. To study this, this was the specific study which was done. It was a phase 3 randomized double-blind placebo-controlled multicentric international study. Patients included were stage 3 locally advanced unresectable who have not progressed after receiving a definitive concurrent chemotherapy with platinum. Must be 18 years or older with good performance status, estimated life expectancy of more than or equal to 12 weeks. And the treatment was started from somewhere between 1 to 42 days of post-concurrent CTRT. The durvalumab arm received durvalumab 10 mg per kg once in 2 weeks for up to 12 months. Their number was 476. The placebo arm received the placebo drug of 10 mg per kg again for 12 months. The co-primary endpoint was overall survival and progression-free survival by independent assessment review. Key secondary endpoint was overall response rate, duration of response, safety and tolerability, and patient-related outcomes. These were the endpoints which were described in the trial. So if you see the patient's baseline characteristics, both groups are very well matched, including the stage, performance test status. Age was somewhere between 31 to 84. Median age was about 64. There were about 6% of the patients who were EGFR positive. Majority of them were EGFR negative. There were about 25 to 30% of patients whose EGFR status was not known. Again, patients with PDL expression were also included. About 36% patients PDL expression was not known. The TC of less than 25% constitute for in about 40% of the patient. More than 25 was seen in about 25% of the patients. About 25 to 26% of the patients received induction therapy. Almost everybody received concurrent chemoradiotherapy. So there were about 27% who received induction chemotherapy in this trial. So this is the updated 5-year overall survival data. If you see at the first year, the difference was somewhere around 9%, so which continued to be there even after 5 years. If you see the survival data in the placebo arm, it was about 33.4%, and in the durvalumab arm, somewhere about 43%. The median overall survival in durvalumab arm is about 47.5 months compared to 29.1 months in the placebo arm. So this is the first and only immunotherapy to show they demonstrate about 42.9% overall survival at 5 years compared to any other drugs used before. Looking at the progression-free survival at the 5 years, the median PFS in durvalumab around 16.9 months compared to about 5.6 months in placebo arm. The hazard ratio being 0.55. At 5 years also, there is a difference of almost 14%. Again, this was the first immunotherapy to show a sustained and durable progression-free survival of 33% at the 5 years. So hazard ratio, if you see, almost remained around 0.7 from 2 years to the 5 years. And even at the 5 years, there seems to be a benefit with the durvalumab according to specific data. If you see the pre-specified group, almost every group benefited from that of the drug, irrespective of the sex, smoking status, stage. So EGFR positive or negative. However, EGFR status was in very less number of patients. PDL expression less than 25% or more than 25%. Every group benefited by that of the durvalumab. Again, this is showing the PFS benefit. Again, PFS was seen in beneficial in almost all the arms, irrespective of whether they had EGFR or the smoking status or PDL1 expression. So, according to that, the racist progression, there is a decreased rate of progression about 45.4% in durvalumab arm compared to that of 64.6% in placebo arm. Thereby, about 25% of the progression was delayed in durvalumab compared to about the placebo arm. Majority of the progression in durvalumab happened in intrathoracic, thereby telling that durvalumab about 85% of the purely limited to intrathoracic, not to that of the systemic. This is showing that even the intrathoracic progression, it took time in the durvalumab arm compared to placebo arm, almost about 16 months compared to that of the placebo arm, hazard ratio being 0.55. Subsequent treatment, even after discontinuation of the durvalumab, was also better in durvalumab arm compared to the placebo arm. About 33% of the people received durvalumab arm subsequent therapy, whereas about 46% in that of the placebo arm. So you can see that though the numbers are very small, but there seems to be that even subsequent therapy seems to be beneficial in a patient who have received durvalumab compared to that of the placebo. So safety, if you see, there are about 30% grade 3 or 4 side effects in durvalumab arm, about 26% in the placebo arm. Discontinuation rate were about 6.6% more in the durvalumab arm compared to that of the placebo arm. Pneumonitis, there was about 6 to 8% more in the durvalumab arm compared to placebo. However, it was not significant. So again, safety based on time of radiation between the two arms. But however, there was some difference in the pneumonitis arm that was more in the less than 14 days. But after more than less than 14 days, if it is more than 14 days, that difference seems to be of not much of difference. So the conclusion of the study, they concluded that the 5-year data from Pacific trial demonstrate robust and sustained overall survival with durable progression-free survival benefit with the Pacific regime. There is to be estimated 42.9% of the patient randomized to durvalumab remain alive at the 5 years compared to that of the 33% in the placebo. And about the third of the patient relive free of disease progression compared to placebo, which is only about 19%. The Pacific regime is now being investigated with different concurrent radiotherapy regimes, including in the sequential concurrent radiotherapy arm. Another very important thing is that durvalumab is also being investigated in combination with concurrent radiotherapy. Results are awaited to see. So with that, I'll conclude my talk. Thank you.
I was just about to prompt that about 5 minutes left, and then you completed. Thank you so much. It was essential and very informative at the same time. I'm sure many of us are putting that into practice, and luckily we are getting those subset of patients. Earlier, due to lack of whatever corporate or anything, we are just being able to incorporate this practice actually. So So thank you, Dr. Suresh Babu. Now, can we move on to our next session, the first debate of the day, the topic being EBS in mediastinal nodal staging in non-small cell lung cancer. To speak in favor of the topic, we have Dr. Arvind Krishnamurthy, a surgical oncologist from Chennai. And to go against this is Dr. Sanjeev Kumar Mishra, radiation oncologist, Bhubaneswar. And we would have our expert opinion from Dr. Prashant Mohapatra, pulmonologist from Bhubaneswar. So can we start it now? Thank you.
Yeah, thank you, madam. Thank you, Dr. Romila, and thank you for the organizers. I think we need to enable, that's fine.
Yeah, timer is on, yeah.
It's on. I just realized, I think it's a vast topic, the time is less, but nonetheless, I guess, I'll make my points. Mediastinal staging, very important prognostically, also helps in treatment planning. N2 disease, generally we don't operate first. N3 disease, we almost never operate. Why mediastinal staging? PET and PET-CT, low rates of accuracy for mediastinal staging, around 80% sensitivity and specificity. 20% sub-centimeter nodes can also have disease, and non-avid nodes also can have disease. So essentially, we need to do mediastinal staging. And how? Either endoscopic or mediastinoscopy, and I'm going to talk for the endoscopic approach. Traditionally, mediastinoscopy was considered gold standard. Generally, these stations 2R, 2L, 4R, 4L could be accessed by a traditional mediastinoscopy. Extended, you could access by either a VAMLA or a TEMLA. You could access levels 5 and 6 as well. But the important issues with mediastinoscopy, although I'm a surgeon, I must say that there is involvement of general anesthesia, less complications. Nonetheless, complications are there in skilled hands as well. Some of them potentially are life-threatening, and mortality also can happen. Over the years, what has happened is clinical practice guidelines have said that the initial staging for the mediastinum should be minimally invasive as much as possible. You have the ACCP guidelines, the ESTS guidelines, and also the European Society of Gastrointestinal Surgeons, ERS-STS guidelines. And mind you, all these guidelines are 2013, 14, and 15. They realized that, you don't really have randomized controlled evidence, but nonetheless, the guidelines say. But over the years, what has happened is the US EBUS combined approach has supplanted cervical mediastinoscopy. Almost all levels of mediastinal lymph node stations are able to be accessed. Now, I would, my opponents would suggest that, the limitations are there, 13 to 15%. You just do identify some metastatic lymph nodes. And that's the reason why the majority of the guidelines say that even if you have a negative EBUS in US, you must have a confirmatory mediastinoscopy. And this was largely based on the ASTER trial. And also, a lot of other guidelines also recommend the same. But now this statement is being challenged by a variety of evidence that has come up over the years. Some clinicians actually do not recommend mediastinoscopy, and a large meta-analysis of 42 trials, 42 studies of more than 3,000 patients actually said that similar proportion of unforeseen N2 disease was there without a prior mediastinoscopy as well. More recent meta-analysis suggests that considering the performance and safety of EBUS, EBUS could actually replace mediastinoscopy for invasive, more mediastinal staging. And the most recent meta-analysis or randomized control evidence is the MEDIAS trial. It was a non-inferior trial, 360 patients, multi-center across both tertiary and secondary institutions, and hence you could have real-world evidence. Primary outcome was again presence of non-foreseen N2, and secondary outcomes were the 30-day. So what did it find? Both on the intention to treat as well as a per protocol analysis, unforeseen N2, the rates were exactly the similar. So the trial by and large concluded, I'm not going to too much of evidence, that mediastinoscopy is unnecessary after negative endosonography, and proceeding to resection after a negative endosonography was non-inferior to a confirmatory mediastinoscopy approach. So what did it say? A confirmatory mediastinoscopy actually reduced the unforeseen rates by a mere 1%. And what is the other trade-off? A 10-day delay in resection, a 6.3% morbidity, less than a percentage of mortality, and a repeat general anesthesia in almost all the patients. And the costs were around $6,000 US, which could be decreased by not performing a mediastinoscopy. Of course, most of the false negative EBUS was in minimal N2, single station N2, and we all know that you can perform upfront surgery in these settings as well. And we all know there's no difference in survival if you go the NACT plus followed by surgery, as well as surgery followed by adjuvant chemotherapy. So even if you are to operate these minimal N2 or single station N2, you're not compromising the survival. And in the era of immunotherapy, all these things are sort of completely different. Now, coming to the real world data, there are issues with availability of equipment, availability of expertise and quality assurance, and availability of a dedicated multidisciplinary board. And this was an Indian publication which was published in the CRST, and I had the opportunity to write an editorial. 82% of the responders preferred EBUS as the initial approach, and mediastinoscopy was available only in about 50% of the responders. So I conclude by saying that accurate mediastinal staging is integral. It avoids the potential dangers of under-treating and over-treating of the patients by accurately staging them. There seems to be a great variability in the population, but over the years, what we have found is that there seems to be a growing popularity of the EBUS-EUS combined approach and a diminishing role of mediastinoscopy with every passing year. And now we do have randomized controlled trial to sort of, substantiate these evidences. I would stop here.
Thank you. Yeah, I was about to stop you. It was already time, but then now, can we have Dr. Sanjeev going against it, sir?
Yeah.
So, please.
I would like to share this slide. Yeah. So, Dr. Biswas gave me the opportunity to fight with a surgeon who is doing all this procedure. I am a radiation oncologist. So, am I audible?
Yeah, you are, sir.
Yeah. So, I thought of presenting this, then I thought, whom I am going to fight? I am going to fight with somebody who is having a big weapon. I don't have still, I do believe that probably what he concluded is fine. But at the same time, when I looked into the literature, many things I got because I'm not a surgeon. So definitely I am going to prefer some procedure which is not invasive.
So today radiation oncologists use cyber knife. So you are also
exactly not invasive. That is what I was thinking there. I wanted something which is not invasive. So that's what we need to have the mediastinal staging by many things like a CT scan, multi-slice CT scan, PET scan, and some sort of artificial neural network related PET scan, which I was not aware of the thing. I saw it then mediastinoscopy, obviously video assisted mediastinoscopy. So if you see all the procedures which are not invasive, starting from it has got some specificity, some sensitivity, and a positive predictive value and a negative predictive value. But finally, the combination of US-NA and EBUS-NA, if you do that combinedly, probably it is the better. So I am directly coming to my last part of the slide, because all the thing like a CT scan has got a prostate cones, at the same time you have a less specificity and sensitivity. Obviously, if you are doing a multi-slice CT scan, maybe it is bit of higher, but not up to the mark. And at the same time, if you are doing a PET CT over that, maybe you are going to get more. So the last one, what I'd like to say is a mediastinoscopy, probably it was the standard of care. What my opponents, Dr. Krishnamurthy, presented was like with mediastinoscopy versus EBUS-NA and or something like that. He did not look into the other part. Obviously, it is fine. But at the same time, if you see the sensitivity like a CT, this is a CT1, and at the same time, if you are getting a transbronchial needle aspiration, it's around BATS is 99%, specificity is 100%, predictive value is 100%. So that is what a big confusion came. There is a little bit difference between the combined EUS-NA or EBUS-NA with a multi-slice CT. So you can see here actually. You can see the sensitivity of everything. You can see here a multi-slice CT scan has got a negative predictive value of 98 to 100%. And positive predictive value of around 94%. specificity is 92.5%, sensitivity is on 94 to 100%. At the same time, you can see here the lower one is the US EBUS. It's more or less the same, little bit difference only. Yes, there is definitely superiority of US and EBUS, obviously. So then what we need to do actually, when a patient comes to us, everywhere you are not going to get the facility. What we need to do, you do a CT scan. Obviously, if you are getting an N2 or N3 disease, no further investigation. If you are getting in a CT of like N0 or a borderline stage 1, stage 2 disease, then you can go for a PET. And the PET is going to decide whether you are going for a BAT assisted or BATs or like a EUS or EBUS assisted needle aspiration. So in a PET negative, it's a peripheral disease in a stage 1. Maybe you don't need, even you can believe in PET, you don't need further medicinal workup. The only thing is that whenever there is a doubt like a PET negative in a medicinum, and at the same time it is not a peripheral disease, maybe bit of advanced disease, there only probably you need, and the percentage of that is really very less. If you are getting a PET positive, don't get biased that you are not going to operate. Definitely you need a tissue diagnosis. There also you can go for the EBUS or EUS guided, and because EBUS, EUS, the endoscopy you have to combine, because there are some lymph node station which you can approach by EBUS and some by EUS. So that is what things are. So what I would like to conclude is everywhere you are not going to get the same facility and expertise also, not only facility, expertise also. And EBUS itself cannot image or samples from subaortic paraesophageal lymph node. That's why EUS we are combining. And there are certain contraindication for EBUS, like cardiac comorbidity, like somebody taking aspirin, you are not going to do a FNA, or sometimes like somebody has a coagulation disorder. So they are only. Otherwise, still I would believe, yes, you should go for a this thing, but always don't think that you don't have that facility, so you cannot go for a surgery. Maybe that you need to assess exactly. Thank you very much.
Thank you for completing your time. But then now I think it's time for rebuttal from Dr. Arvind.
Yeah, I think.
Any refuse?
No, I've made my points, I guess.
I surrender myself.
No, what I would suggest was initially, of course, they were considered complementary. No? You do EBUS, EUS, and then subsequently you sort of do a confirmatory. But now more and more evidences are coming that you don't require sort of the confirmatory mediastinoscopy in all cases. If at all you'd require, I must say that you require it in possibly N1 disease. In which the chances of having an N2 or N3 may be possibly higher. But by and large, for an upfront N2, N3, you don't really require much of a cervical mediastinoscopy. And for an N0 and N1, you can be very, very selective. So more and more evidences, and now you have randomized controlled trials like the MEDIAS trials, despite some of the limitations, but it's an excellent trial in real world to have a randomized controlled trial. So I feel that, EBUS, EUS combined approach initially, almost everywhere it's been done. The use of mediastinoscopy seems to be diminishing more and more. This is my final thoughts. And thank you, Biswas. Thank you, everybody, for the opportunity, and hand it over to the moderator, Dr. Prasanta, to his final comments.
Good evening, everybody. I think today's topic is EBUS in mediastinal nodal staging in non-small cell lung cancer. And I agree with Dr. Arvind Krishnamurthy. I agreed also Dr. Sanjay Mishra. And there is accurate staging of the mediastinal lymph node in a resectable non-small cell lung cancer. It is very important to determine the stage of tumor, not only stage of tumor, it's also guide for subsequent management. A staging process typically begins with a PET CT or CT scan, what you discussed, and however imaging is not adequate, so need to tissue is the issue. I think everybody agree on that. So whether and mediastinoscopy has been, I agree with Dr. Krishnamurthy that, and mediastinoscopy has long been considered the gold standard of staging mediastinal lymph nodes. But recently, what has happened, EBUS, what you've already discussed, the EBUS has become a standard of care. Whether it's US or EBUS, whether any approach may be it's possible. And such an intranodal, and things have come up, actually new things has come up Previously, we were using 21 gauge needle. Now the 19 gauge needle is used as a biopsy. Not only not used, and that thereafter comes a forceps biopsy, lymph node forceps biopsy. Forceps will go inside lymph node, and that didn't come out actually very well. Later on, it's come to EBUS cry biopsy that is coming up. It has started in some big centers. So that and esophageal ultrasonography, these all that has increased the sensitivity and specificity of the nodal metastasis. And US or EBUS FN also capable of assessing the N1 disease and obtaining. What I agree that Dr. Krishnamurthy told, and the trial also he discussed it. I think it's about the Astra trial. So that's it. Video metastasis that also developed. And that can detect up to sensitivity from 85, 90, 70, 80% to 85%. And I believe that confirmatory metastroscopy is a choice, and it's it's a not say that this is required or not required. I can difficult to say, but although that's that if you combine both, I think the sensitivity is going up to around 95%. And omitting confirmation, if you omit also metastroscopy after negative, it was probably agree with that. What that means some unforeseen N2. That is some that what you mean that means what means that on that Netherlands trial has shown that unacceptable increase of N2 rate on the basis of clinical or non-inferiority margin. What I mean that non-inferiority trial, that means that demonstrate that the test product is not lower than a particular, suppose it is 95% correct, it may be we have a limit of non-inferiority margin is 2%, maybe 93%. So it is not that much difference. So there's none that has been proved. And however, the confirmatory metastroscopy necessary is the matter debate. And it is not the commonly performed in many places also. And to address the question, that has performed. This has been already debated. So I believe that it is again the team decision. And I believe that newer technique of EBUS or endobronchial ultrasound has been coming edges. It is going to be a choice, and that cannot be replacement of video metastroscopy. I believe that I come to end with this.
All right. Thank you. Thank you so much. Well concluded. It was a very balanced kind of a approach. And yeah, it is patient to patient, case to case, team discussion and decision. Now before going on to the next panel discussion, I would like to announce the result of the quiz, which we already have in our hand. So for question number 1, the winner is Dr. Mohalik. Question number 2, Dr. Sivanshu. Question number 3, Dr. Suresh Babu himself. Question number 4, Dr. Sivanshu again. And question number 5, Dr. Swab. So big round of applause for the winners. Over to you, Dr. Engineer. Thank you.
Romila, you can switch off your video so that you will have a bandwidth.
Am I audible? Dr. Indranil Ghosh is there with us?
He's there.
Yeah, I am there.
Yeah, sure. So can we please start it, sir?
Yeah. I would request you to share the slides.
Yeah. Anita, can we have the slides shared?
Yeah.
Sharing the
Meanwhile,
slides.
I will welcome the panelists, Dr. Amit, Dr. Shefali Sardana, Dr. Rakesh Roy, and Dr. Satyajit Rath. I hope all of you are available.
Hi, Indranil.
Yes, sir.
Yeah.
Hi, Dr. Indranil. This is Dr. Shefali here.
Yeah. Hi. So today we are having a discussion on extensive stage SCLC. It will be a case-based one. So just step by step how we approach in our clinic. Next slide, please. So this patient is an 81-year-old male. His history of he presented in January 2023 with shortness of breath. His ECOG performance status was 3 at that time. There was no specific past medical history. He had smoking history. Treatment and workup before coming to us, he had a left pleural effusion diagnosed, which was drained, and fluid cytology revealed metastatic carcinoma. Next slide, please. So we ordered a PET scan. You can see here there is a left pleural effusion along with metabolically active pleural deposits. Next slide, please. Yeah, the same thing in cross section. A lot of metabolically active pleural deposits. No specific primary as such was seen on this scan. Next slide. So this is the report. Multiple nodular pleural thickening on the left side, multiloculated left pleural effusion. Along with that, metabolically active small left hilar, prevascular, left epiphrenic, and celiac node. Next. So what should be the next plan for this patient? True-cut biopsy, thoracoscopic biopsy, role of MRI brain. We start with Dr. Amit.
Yeah, so definitely, sir, first we have to prove whether it's a malignancy or not. So a biopsy is needed, whether if it's feasible through a true-cut CT-guided biopsy, or if not feasible, definitely a thoracoscopy can be done and a pleural biopsy can be taken through that. And thereafter completing the staging workup, MRI brain will be needed for this patient to rule out whether it is any brain mets are there or not.
Okay, so all of the panelists would agree that preferably true-cut biopsy, if that is not feasible, thoracoscopic biopsy.
I would take one step further to prepare a cell block out of the pleural effusion and do the markers, basic markers at least on that. If that gives us the answer, I think we can avoid thoracoscopic biopsy in 81 years gentlemen. Of course, if we do not get that cell block yield, so that is the best way to go for it.
Yeah, point well taken. In this patient, it was tried, but it was insufficient for IHC. So next slide, please. Here we did a true-cut biopsy. Next slide. Slide is not moving. Yeah, the true-cut biopsy reveals a metastatic small cell carcinoma, and the IHC, as you can see here, chromogranin, cytokeratin, pan-cytokeratin, and chromogranin synaptophysin, these are positive with Ki67, 99%, and the other relevant markers were negative. Next slide. MRI brain, as was rightly pointed out, needs to be done in this patient, which did not reveal any brain metastasis. Next slide. So what treatment for this patient? So many questions. Leave aside the treatment given to this patient. Many questions are there. This patient is 81-year-old with poor performance status. So how do we approach? We give only supportive care or lower dose chemotherapy, single agent chemotherapy, or multi-agent chemotherapy, or chemotherapy plus chemoimmunotherapy. So I will start with Dr. Rakesh.
Hi, Indra, can you hear me?
Yeah.
Yeah, so Indra, the conventional or traditional booking was a patient of small cell carcinoma of the lung. If the patient is diagnosed, luckily, should not end up in the ITU because it is the widespread disease that actually reduces the performance status of the patient and the tumor burden. And because in general, small cell lung cancer patients actually respond very well to chemotherapy. So before calling it a day, one can always give a challenge of chemotherapy to these patients to see whether the patient is responding. And if you give the chemotherapy to the patient in the right time, then there is a possibility that the performance status can improve, the tumor burden can be controlled to an extent, and you get some satisfaction. In this particular case, if I give chemotherapy, I would add atezolizumab with the patient can afford, for the simple reason atezolizumab added.
No, first, which chemotherapy that you need to tell me.
Yeah, so it is carboplatin and etoposide. 3 days of etoposide.
So you will give combination, not a single agent carboplatin
not
or
single
something
agent.
like.
Yeah, 3 days of etoposide, 1 day of carboplatin, and I will give this patient some form of immunotherapy, because I think the immunotherapy, if added to this particular chemo backbone, is not going to create any added toxicity. What I've done is I have met or come across these kind of patients 3 times. I actually ended up giving the immunotherapy on day 4 because the patient couldn't arrange, but the patient successfully completed the 3 days of chemotherapy. And to be honest, unless the patient has some contraindication like creatinine, which is maybe 3, or the patient has acute sepsis, patient has high fever, or maybe a very severe, I mean, I'm not talking about the paraneoplastic syndrome, the other added problems. I don't think there is a major contraindication to chemotherapy for this patient.
Okay, Dr. Shefali.
Yeah, so I would start with the single agent carboplatin first, of course, in a PS3, because I mean, I presume that PS3 is because of disease only, because he is not having any other comorbidities. So if he's tolerating well, the next step would be, of course, to add atezo to it and subsequently etoposide. But what I do in my practice is 1 or 2 cycles, I give carboplatin and etoposide on a weekly regimen. See if the patient is improving, tolerating well. Then I step up to the whole day 1 to day 3, Q3 weekly types. But of course, I'll start with single agent carboplatin here.
So if you are using single agent carboplatin or this weekly regimen, would you use atezolizumab at the same time or only when you go to the standard 3 days regime?
So if I start with only carboplatin, what I generally do, I do not add atezolizumab here. I give only carboplatin on a weekly basis for at least 3 doses. If patient tolerates well, if he's showing the signs of improvement, the second step is carbo-eto weekly, and then I add on atezo on day 1.
Okay, so stepwise increment in the treatment intensity.
Yes.
So now one question is that in poor performance status, we can give chemotherapy in SCLC if it is due to the disease burden. So that's is well accepted. But what about atezolizumab? The study included only performance status 0 and 1.
Absolutely.
Can we extrapolate that to 2 and 3?
See, practically, I don't see any contraindication in PS2 and 3 because, I mean, it is permitted in various trials at elderly age and these kind of PS on the basis of PDL1 status also. So practically no contraindication. But of course, subjecting atezo in small cell and that to that small quantum of benefit, first I need to see whether what signs of my patient shows improvement on chemotherapy. So that is why it is a step-on process.
Okay, thank you. Dr. Amit?
Yes, sir. So I'll completely agree with ma'am. We start similarly with a single agent carboplatin upfront, and thereafter 1 week responding, going with the full dose and adding immunotherapy thereafter once the patient is slightly better. And performance status doesn't matter with small cell lung cancer and lymphoma. So these are the diseases, the performance status deteriorates only due to that disease. So we may add on, the treatment has to be given if other causes of poor performance status is ruled out.
Yeah, so in our patient, his performance status improved to some extent with supportive treatment, and after discussing with the family, we gave a reduced dose of carboplatin etoposide only, 3 days regimen, but with much reduced doses along with atezolizumab from day 1. And from the second cycle, that after the Patient improved, we increased the dose of carboplatin and etoposide as well. So 3 cycles were completed. Next slide. Can I have the next slide? So after 3 cycles, the PET scan here shows a complete metabolic response. So there was no residual disease at that point. Next slide. Same here, the cross-sectional image. Next slide. So significant reduction in the left pleural effusion with disappearance of left pleural deposit with total disappearance of FDG avid nodal lesions. Suggestive of complete metabolic response. Next slide. Yeah. So let's say we completed 4 cycles of carboplatin, etoposide, and atezolizumab in this patient after the PET scan. So total 4 cycles, and now we have to decide on 2 things: cranial radiation and thoracic radiation. For that, I will go to Dr. Satyajit Rath. Dr. Satyajit, are you there?
Yes, he is here. Dr. Satyajit, you are not audible. Yeah. Better, but no, still not very clear.
Audible now?
Yeah.
Yeah. No, go back. Don't move the slide. Yeah. So after 4 cycles of chemoimmunotherapy, complete metabolic response, what is the role of cranial RT and thoracic radiation? You are not audible.
Am I audible now, sir?
Yeah. Clear.
Sir, just give me a minute. Yeah. Am I audible now, sir?
Yeah, sure.
Yeah. So the thing with extensive stage small cell lung cancer is that we give thoracic radiotherapy to those patients who have some form of residual pulmonary disease or very low volume extrathoracic disease after the completion of carbon detopo. The scenario has been a little bit different for us after the implementation of immunotherapies like durvalumab and atezolizumab. As of now, we don't have any concrete evidence. Few years back, we had an ASTRO and ASCO recommendation that we can give thoracic radiotherapy to those patients with good performance status if they have low volume extrathoracic disease after the completion of the chemo and immuno 4 cycles, initial 4 cycles induction, then we expect a good performance score and we have some residual disease. In this patient, we don't have any residual disease and we have only pleural effusion left. So the role of thoracic radiotherapy is controversial in this patient. We have ongoing trials like triplex trial, TREASURE and RAPTOR for particularly this regime and thoracic radiotherapy, and then luminance study for durvalumab, which are going on to finalize the answer. Some centers in India still practice thoracic radiotherapy 13-10 fraction, starting with the second cycle. So in this patient, I'll still not prefer, but as ma'am said, that patient has only PS3 due to the disease, but the pleural effusion is profuse. So we may skip.
Now he is not PS3. Now he is PS2. If you get after chemo.
Yes. Yeah. After chemo, he is PS2, sir, but there is no residual disease. So for CMR, we don't need TRT in this patient particularly.
Okay.
For cranial radiotherapy, we need to evaluate 2 things. Patient's PS is 0, 0 to 2. So yes, we can give cranial radiotherapy. We also need an MR post completion of the chemotherapy. So second MR. There is still some doubt as to whether MR surveillance alone versus MR surveillance with PCI, which arm is superior to other. So the studies, Maverick study is still going on. We don't have the complete results. We expect results in 26, 27. But since the patient has a very good response and the patient's PS has improved, and we expect the overall survival to be improved after the completion of the first few cycles of chemotherapy, personally I'll consider PCI 25 in 10, but no thoracic RT.
Okay, now, as you correctly pointed out, with the advent of immunotherapy, these things are a bit confusing. So, these patients will be on atezolizumab or durvalumab, whatever, maintenance. So, along with that, are you comfortable in giving RT in combination with immunotherapy, or would you like to stop immunotherapy for some time and then restart?
So, personally, I have only one such experience in which I have attempted I have attempted PCI with atezolizumab. The patient did fairly okay. But in terms of giving with immunotherapy, we still don't have any concrete evidence. As I said, all the trials, Triplex, Treasure, Raptor, Luminance, the studies are still going on. So we'll have to wait maybe till 26, 27 before you get a concrete result in a hand.
Dr. Shefali, your view?
Yeah, I agree with the previous panelists. So in basically the trial, which included atezo and chemo, I mean, these kind of liberties were not allowed. So can't say whether these will really benefit him over and above the immunomaintenance. And as well as he's 81. So what kind of benefit does PCI give us? Thoracic RT, I would not give. But of course, like PCI is a matter of debate, because there is only one Japanese study which showed that it gives some benefit. But at 81, probably practically, I would not prefer to give PCI in this case.
I agree, ma'am. I agree, because see, I'm still telling that I'll prefer, and it's an MDT discussion after the evaluation. I agree, it's a difficult thing because of the age, but since we just expect some improvement, one point I agree with you that we might expect some neurocognitive deterioration after PCI. So yes,
completely agree with you. Completely agree. It is individualized thing on a MDT basis. Yeah.
Okay. So this patient, as I mentioned by all the panelists, we did not give any form of radiation. We just continued on atezolizumab. We received 4 more cycles. Next slide. After that, he developed a progressive disease in the left pleural deposit and lung nodules only, no extrathoracic disease. Next slide. So what are the options now in second line treatment? Dr. Amit?
So it all depends on the duration of the relapse. So if it is after 6 months or so, I'll like to re-challenge again with carboplatin and etoposide with this patient. And if occurring before that, then might be the second line option of irinotecan or topotecan, anything to be planned in this patient.
It's not, it's definitely.
Yes, sir?
You are muted, sir.
So it's only 4 cycles of maintenance, so like 3 months. So what would you prefer in this patient?
So if it's only 3 months, then in that case, surely going for the second line therapy with irinotecan this patient.
So you would prefer irinotecan.
Yeah.
What about topotecan?
It can also be given. It's the personal preference. Though topotecan has got the maximum data, but it's easier to handle irinotecan in my practice. So it's basically the practice
Would you
wise.
continue immunotherapy along with it?
Since the patient has progressed now on immunotherapy, then I don't think there is any further data supporting them. I will stop immunotherapy and continue only with irinotecan.
Okay, fair enough. Dr. Rakesh?
But we normally and just giving an example in Indonil, in CA ovary, what we do is we look for the platinum-free interval, which is to the tune of 6 months, 9 months, 12 months, the way you actually classify it. But in small cell lung cancer, the threshold comes down, it is about 3 months. So there is a possibility of actually repeating the same regimen after 3 months. But this, I believe the patient has actually come back with the disease within 3 months. So I agree with Amit, there is no problem in giving a new chemo backbone. I would like to continue with immunotherapy for the sole reason, understanding that it did not help much. in case the patient responds, then after a certain point of time, I'll have to stop the chemo and then I have nothing else to offer. So maybe in the maintenance phase, you never know what chemo immuno can do in the second line. There's not much data. However, if the patient would have relapsed after, let's say, 4 months or 5 months, I probably would have re-challenged this patient with the same chemo and the plan would have been the same.
Right. So in this patient, which chemo would you prefer?
Yeah, so this patient is too early relapse. Complete response within 3 months, the disease has started coming back. So the effect of the chemo or immunotherapy is not very long lasting. Therefore, I might go for topotecan in this case.
Okay. Dr. Shefali?
Yeah, so my decision would depend upon a couple of things. Number one, whether the progressive disease is at single site, which is localized or loco-regional type, that is oligoprogression, or it's a diffuse one. And the second, what is the performance status now for the patient? If it is a oligoprogression at a single site, maybe small mass is appearing again this time. I would always discuss in the multidisciplinary tumor board about option of utilizing radiation here and continuing the immunomaintenance. That would be in my mind. And of course, if it is a pleural effusion appearing again or a massive disease, then if the performance status permits, I agree with the previous panelists that second line chemo, maybe topotecan or irinotecan. I would personally prefer irinotecan here because topotecan 5 days regimen at 81. I find it difficult in these patients. So irinotecan weekly basis, day 1, day 8, every 21 days would be my choice in this patient if there is a diffuse progression.
Yeah, so very valid points. So if it's oligoprogression, we might buy some time by giving radiation, but here it was more of a diffuse thing. So we again did not go for radiation. We did MRI brain, that was clear. So we just gave second line chemotherapy with topotecan. Next slide, please. So, so before that, I'll just explain what happened. So with topotecan, he tolerated it reasonably well. The hematotoxicity is more with topotecan, but that part was not there, even though there was some fatigue. So after 3 cycles, he had a good response, and after 6 cycles, ultimately it progressed, and now he's on base supportive care. He is still there, but on BSc only. So that brings us to the end of the discussion. Any other points from the panelists? SCLC management.
So if I'm allowed, can I discuss a case? I think we have 7 minutes more in hand. I'll take a couple of minutes. So we have a 71-year male who came to us about 5 months back, as he was first admitted for pneumonia. Then it came out to be a malignant effusion, and then a small cell, extensive stage small cell carcinoma with bony mets in the sacrum and also brain mets. But brain met wise, he was asymptomatic. So the standard carbo-eto we did, and then we gave him atezolizumab from the second cycle onwards. For the first cycle, we had to give it in ICU, so we were very conservative in giving. But with that also, he showed a significant improvement. Now from the ICU bed to walking to the chamber, in the OPD. So post 3 cycles, there was good response, and post 6, the PET-CT was the gap was not more than 3 months. So we waited. We gave 1 maintenance of atezo and called him for PET-CT, followed by further to see response. But suddenly he fell sick. He came again to the emergency, and we thought it is progression because there was effusion. And very interestingly, the thing is the effusion was negative for malignant cells, which initially was positive, and he grew gram-negative bacilli. So he was in septic shock for the kind of presentation that he did recently. And then we did, after he recovered from those things, we did a PET-CT. Now that showed previous lesions were kind of resolved, but the new lung lesions that were seen is question mark progression. But brain mets also, the previous brain met which was there, we have additional right cerebellar lesion, but then the patient is completely asymptomatic. After having given him the sensitive antibiotics, he recovered like again a complete U-turn, again on his toes, again walking. at that time we thought when we saw the PET report, we thought we should go ahead with again the topotecan or irinotecan. But then we thought the patient is 72. He told let me just meet my people back in village. So he went and came back, and he's so fit, so well. We didn't get that feeling to change the drug. So what we have thought is let the atezo continue, take a radiation opinion for the cranial irradiation if required. But typically, I don't know why he is not symptomatic. None of the brain mets, none of the bony mets, nothing. So, but then the PET CT is saying progression. So, can we have some opinion here? Will bevacizumab make some difference adding to the ongoing atezo? We don't want to stop atezo because clinical response is what we can see, a very good clinical response.
So there can be two possibilities here. If you think that it is a pseudo progression, you can always wait if patient is clinically better and give say 8 weeks interval and do a early PET to reassess.
Yeah.
Or if it is feasible, I would go and do a biopsy of those new lesions. So if that confirms a progressive disease, because these are new lesions appearing, if this is a progressive disease, so then certainly you have to decide on the basis of performance status whether patient can beg those 8 weeks of continuing immunotherapy.
That's
so or on the other extreme scenario, if you confirm that it is disease, I would like to add on irinotecan, and because performance status is improved with immuno and he has fetched couple of months, I don't mind even continuing immuno along with the irinotecan. Yeah, that would be my third preference.
Ma'am, any role of bevacizumab? Like,
I have never
No.
used practically here. No.
All right. Okay. Thank you. Thank you so much.
Okay, thank you all the panelists.
Thank
and
you.
Thank you the organizers.
I mean, like a big thanks to Dr. Indrani. He compiled the session well in time. He gave us 7 extra minutes. I consumed 4 of them. So let's now, thank you very much. Thank you to all the panelists. Thank you, Dr. Indrani Ghosh, for moderating it so well. We now move to the next session, which is a talk on the role of IO in early non-small cell lung cancer. And the speaker is Dr. Satish, medical oncologist from Bengaluru. So Dr. Satish, over to you now.
Thank you. Thanks for organizer giving me opportunity to speak on role of IO in early lung cancer. Can I share my slides?
Yeah.
Is it
I
visible
think you're
now?
being able to. Yeah, it's visible.
Yeah.
Yeah.
Okay. Thank you. Thanks for introduction. Let me start the talk on the role of immune checkpoint inhibitor in early lung cancer, especially non-small cell lung cancer. We all learned about how we treat advanced non-small cell lung cancer. We try to see that dissect it into biologically like a driver mutation positive. We try to target with based on the what is the subtype of mutation. If we don't have any that actionable mutations, we'll try to treat with the chemo immunotherapy. You can see here like even irrespective of PD-L1 expression, we'll try to combine chemo immune checkpoint inhibitor with chemotherapy. Sometimes like more than 50%, we might treat with a single agent. You can see dramatic improvement in the OS benefit. Median OS has come more than 2 years, and patient are like try to survive more than 15 years. That has changed in a last couple of decade. Like 1 decade, we can see that immune checkpoint inhibitor is become a backbone of our treatment now. Coming to the role of treatment chemotherapy in early lung cancer, we can use in early either in a perioperative regimen or maybe in adjuvant treatment. Look at this, we can see that we can try to use like not very early. You can see that here early lung cancer with this stage like 2A, like a 2B and a 3 up to that one, we can try to have a perioperative regimen. Then you can go for a definitive surgery, or if those are already underwent surgery, we might go for adjuvant treatment. There, the role of chemotherapy comes in the picture in early lung cancer. Coming to the meta-analysis of the adjuvant chemotherapy in early lung cancer, you can see here it has made like a lot of changes. It has taken from a couple of like a large randomized studies. Chemotherapy at 5 years definitely improve the and decrease in the cancer-related death from the lung cancer. It is almost nearing 7%. It may be like a non-cancer death, maybe toxicity, but absolute benefit of at 5 years, it is like 5.4. It definitely chemotherapy is there, like in adjuvant setting. What is like a stage 2 and stage 3, and even early one, like a stage 1B and coming to the other, like the strategy of the that early lung cancer, we know that like even now that therapy has evolved in a multiple direction. If you see the driver mutation early lung cancer, Adaro study is there. It is after completion of definitive chemotherapy, or some patient even not fit for chemotherapy. They randomized stratified into adjuvant TKS, that osimertinib versus placebo up to 3 years until the toxicity. It is definitely is made a change in the outcome. Disease-free survival rate is improved like more than the 2 years and 3 years. Now we are upcoming the updated the analysis presented in a various conference. You can see definitely DFS has changed in the practice. Is the like a change of our practice routine, and OS is still immature. Like because we are all learned from all various TKs and also various CDK4 inhibitor, even various molecule. Early we try to see disease-free survival rate has improved. OS we have to wait for more than 5 years to data has to mature. Coming to the consideration of chemotherapy in early lung cancer, we know that benefits of neoadjuvant versus adjuvant. When coming to the especially early lung cancer, it provides an opportunity to eradicate the micrometastasis and increases the pathological response, and also potentially eliminate the live tumor cells into circulated tumor before the definite surgery. This is one of the advantage, and also we can and understand the biology of the disease and titrate the disease various later how we are understanding in the breast cancer. Coming to the adjuvant treatment, like it is definitely, it gives one of the definitive treatment and early fast time, like we can try to in a one definitive modality treatment you can complete it, and also proper staging of the disease will be done. Unless patient is like fit for the surgery, that's difficult. Like adjuvant treatment, like after the like definitive surgery, we'll try to know what are the proper staging we can give, and also properly like we'll give the longer treatment duration at disease systemic control will be there, and also it allows the like recovery from the surgery. It gives the time to understand the post surgery. We can make them subject for adjuvant treatment. Coming to the role of neoadjuvant IO in early lung cancer, there is various trials are there. This is one of the first phase 3 randomized study, Checkmate 816. It is a role like a nivolumab along with a chemotherapy in a resectable stage 2, stage 1B, stage 1B to stage 3A non-small cell lung cancer. There, like a stage 1B, more than 4 centimeter or equivalent to 4 centimeter up to 3A without any like actionable limitations. They are stratified into chemotherapy standard based on the subtypes of histopathology, and along with the nivolumab, one arm is that is a 360 mg 3 weekly versus a placebo. And after that, like a 3 cycle was given, and later underwent a surgery. After 4 surgery, they analyzed the histopathology report, and optional about the adjuvant chemo and radiation was done based on the post surgery histopathology status. The endpoint of this primary endpoint of this study was PCR, and OS and MPR status was analyzed, and exploratory of overall response was analyzed in this. Coming to the primary endpoint, like pathological CR should not have any zero residual viable cells. MPR should not be like, it should be less than 10% residual viable tumor tissue in the primary, including lymph node sampled lymph nodes. And both the PCR and MPR, if you consider, recommended at least a 5-station lymph node should be resected. That's what is important when you are analyzing the PCR, MPR. That was taken into the account in this study. And also the exploratory, they analyze the TNB and also some cell-free DNA, the negativity from the clearance from the beginning of the cytotoxic chemo immunocombination from the at the end of the cycle 3. Look at the baseline characteristic of the this study. The coming to the that age and geographic region and stage wise and histology like squamous versus non-squamous, smoking history, they're all well matched, and even the PD-L1 status and TNB status, they're all well matched between the both the subgroups. Coming to the treatment history, like almost like 3 cycles were completed. New arm almost 94% versus the chemotherapy 85%, and drug toxicity were almost similar. Progressions disease like it is almost similar. It may be other one may be taken into other than surgery. They might be gone for radiation. Here, like type of surgery, you can see here almost like a more number of patients gone in a surgery in a chemo immunotherapy arm. Lobectomy, pneumonectomy, and R0 resections are slight numerically more here with the IO with the chemotherapy. And chance of definite like they may be like cancelled because of the surgery because of the progression of disease and adverse event. Other reason they're all like they're less in case of a chemo IO combination versus the chemotherapy. Look at the response. Primary endpoint is a pathological CR. You can see 10 times, like compared to the chemotherapy, 10 times better. That is a 24 versus the 2.2 percent was noted in the chemotherapy arm. It was statistically significant. And patient with a R0 resection also, it is almost like more than 10 times. That is 30.5% versus 3.2. And the primary tumor, if you take for the intended to population, is also it is a statistically significant improvement in the response. Coming to that subgroup analysis of the pathological CR, look at the irrespective of age, sex, and irrespective of the region, geographic region, and stage-wise, even stage 1B, and like histopathology and PD-L1 status. It's shown that all the subgroup in irrespective of the TNB and type of platinum, it was got benefited. And you can see here like the radiological downstaging also better with IO with the chemotherapy arm. And coming to the toxicities are almost similar. There no numerically appears to be like less in the IO with the chemotherapy arm, but there are no statistical significance between the added toxicity with the chemo immunotherapy arm. Summary of this study, immune checkpoint inhibitor, that is a checkmate 816, it met the primary endpoint of pathological CR by adding nivolumab to the neoadjuvant chemotherapy in a newly diagnosed resectable early stage lung cancer. But the PCR definitely was consistent across all the subgroup, and MPR and overall response also is improved in all the subgroup. And it has become, this combination appears to be safer without adding any toxicity. It is one of the first randomized phase 3 data demonstrating the role of neoadjuvant immune checkpoint inhibitor along with the chemotherapy in early lung cancer. These various trials are there, like with the checkmate other than that keynote 6-7. IMPR study and AGN study and checkmate 717. You can see here, like I'm going to come in the next slide. You can see these are results of all the studies. Already first one I said actually that is the EFS event-free survival rate was beneficial with the first study what I presented earlier, that is a 31.6 versus the 20.8%. Pathological CR is better. Agent study with the durvalumab with the chemotherapy, like you can see here, and here like they continued the durvalumab here only chemotherapy, but first study only neoadjuvant was used. Here you can see that EFS was better and even pathological CR also better with the durvalumab arm. Next, that at pembrolizumab arm, you can see chemo with pembrolizumab 4 cycle followed by the definitive surgery, then later adjuvant treatment and maintenance pembrolizumab was given. EFS was beneficial and pathological CR also beneficial here. And nivolumab and newer molecule, that is neotorch study, that is a torelpimab, like that also got beneficial in the improvement in the EFS and also pathological CR. This is one of the important study. What I say that pembrolizumab study, it has shown that early lung cancer, adding pembrolizumab is also improves the OS benefit, is improved in the pembrolizumab arm, and median OS was not reached in pembro arm versus the 52.4 months in the chemo arm placebo. You can see that neoadjuvant chemo with the pembrolizumab followed by resection adjuvant treatment to pembrolizumab definitely shows a significant improvement in the OS and EFS data. Coming to the adjuvant role, this is the one of the summary
4
of the
minutes to go.
Yes,
Sorry
yes.
to interrupt.
Yeah. The summary, like we try to have the various trials there. I'm not going in depth all the studies here. This is the various studies are there, like various studies like various immune checkpoint inhibitor along with the chemotherapy they try to use. One of the important study I'm going to present is the IMPR like a 01 study, that is atezolizumab role after the resection of the early lung cancer after the adjuvant chemotherapy. Here, like early lung cancer 1B to 2A, 3A up to 3A, like after completion of chemotherapy, the adjuvant chemotherapy was finished, then randomized into atezolizumab versus the breast supportive care, that's placebo. Like they tried to analyze, they tried to go for a 16 dose of immune checkpoint was in analyzed here. Here, like they try to analyze those who are PD-L1 positive and all randomized cases and intent to treat population. They're all well matched across the all subgroup between the stage wise and even PD-L1 status. And here, one of the thing important, PD-L1, EGFR and all positive also some cases were there in all the treatment and treated cases here. Here, the primary endpoint was like DFS. You can see here it was significant. Like at the end of 2 years and 3 years, you can see median DFS was significant, which met the primary endpoint by adding atezolizumab. And also subgroup analysis, it was got beneficial in all the subgroup, except in case of EGFR positive cases. You can see here, I'll tell you, ALK positive cases, EGFR was beneficial, node negative, and ALK positive was not shown any beneficial. Coming to the other all randomized cases, it was shown an improvement in the DFS at the end of 2 years and 3 years. And DFS also, like you can see, the subgroup analysis didn't show beneficial in the EGFR and ALK positive cases. Coming to the OS, it was not mature. It is a pre-planned analysis, like it's as per that, and still require a longer follow-up actually. And
2 minutes.
Yes, summary of this study, that it has demonstrated significantly improvement in the DFS with the atezolizumab when given after cisplatin-based chemotherapy in all resected patient with a PD-L1 positive stage 2, stage 3A lung cancer. Magnitude was benefit was more in case of PD-L1 positive, more than 50%. Here is the hazard ratio was 0.44. But if it's more than like 1 point, PD-L1 1 to 49, it was coming as a ratio was 0.79. It was definitely shown that PD-L1 positive cases should give the adjuvant even sequential treatment. It is one of the first randomized phase 3 data demonstrating the benefit of adjuvant PD-L1 blockade after the surgery and chemotherapy in a case of resectable non-small cell lung cancer. In conclusion, because various immune checkpoint inhibitor, because it's a very short time, by adding immune checkpoint inhibitor, example that is a nivolumab in a neoadjuvant chemo, it definitely improves the radiological response, pathological CR, without any increment in the toxicity. Definitely is made is role in the improvement in this disease control. OS we are waiting. And even the role of pembrolizumab also shown that is both event-free survival rate and OS is shown in the neoadjuvant setting, and neoadjuvant chemo and followed by 1 year of data is there. And adjuvant atezolizumab after surgery and chemotherapy definitely improves the DFS for the patient with the PD-L1 positive early lung
30
cancer.
seconds.
Immune checkpoint inhibitor become the mainstay of perioperative chemotherapy in stage 2 and stage 3 lung cancer. It has become a near future for all PD-L1 positive cases should be used irrespective of the stage 2 and stage 3, and even early 1B also some other data is there. I'll stop here. Thank you.
Thank you. Thank you so much. That was well compiled. Many things discussed in this short time, and very relevant things, in fact, good take-home messages. Thank you for completing it on time. Next week, proceed towards our next talk, sequencing of ALK inhibitors in metastatic non-small cell lung cancer. And the speaker is Dr. Lalatendu Maharana, medical oncologist from Bhubaneswar. We have Dr. Lalatendu with us, right?
Yes, ma'am.
Anita? Yeah.
Yes.
All right.
Hello, good evening, Romila. Am I audible?
Good evening. Yeah, you are audible, but then I can't see you yet.
Okay, now?
Yeah. You are visible and audible both.
Okay, let me share.
Go ahead, all yours. Hand, yeah.
So my slide is my slide visible, Romila?
Yes, yes, it is. Yeah, it is.
So hello everyone, I'm Dr. Lalatendu Maharana. I'll be discussing about sequencing of ALK inhibitors in metastatic non-small cell lung cancer. As we know, non-small cell lung cancer, it is not it is a heterogeneous disease, and it is driven by multiple driver mutations. More than 50% of patients, they may harbor some oncologic driver mutation, in those patients who are never light smokers. And ALK, as we know, is a tyrosine kinase that can be apparently expressed in several tumor types. And in NSCLC, chromosomal rearrangements involving ALK gene loci on chromosome 2 are found in approximately 3 to 5% of non-small cell lung cancer patients. Most common ALK rearrangement, it juxtaposes the EML4 gene to ALK gene, resulting in the novel fusion oncogene, that is the EML4 and EML4 ALK oncogene. Here we have to understand the concept of oncogene addiction, that there may be multiple mutations responsible for the tumorigenicity, but the tumor many times depend upon certain mutation for maintaining its malignant properties, despite the accumulation of multiple gain and loss of function mutation present. So here, if ALK is present and along with it some other mutations are also present, ALK is considered like tumor is considered oncogenically addicted to ALK. So typically these patients are adenocarcinoma, and these are younger than ALK negative patients, and typically it is present in 3 to 7% of non-small cell lung cancer, and brain metastases are more common, usually seen in 30 to 50% of cases. The etiology is unknown. So this table shows these things only, like these are younger patients and usually never are light smokers, and more than 95% of cases it is adenocarcinoma. And here you can see usually EGFR, ALK and KRAS, they are considered as mutually exclusive, but in clinics we get to see time and again patients who are harboring both ALK and EGFR mutation. So how to test for ALK? Testing for ALK rearrangements must be ordered at the time of diagnosis or at the time of recurrence or progression. And since 2018 guideline update, ISC is now considered to be an equivalent alternative to FIS. And so what are options we are having? We are having ISC, we are having FIS, and nowadays one-stop solution is NGS for testing ALK. And so ISC, if it is negative and clinically patient is suspicious for ALK, again this tissue should be subjected for FIS, and if it is equivocal also, it's the tissue should be subjected for FIS. And if it is positive, if it is ISC is positive or FIS is positive, it is considered ALK positive NSCLC. Or if NGS, we are performing NGS. If ALK is positive also in NGS, it is considered as positive. So what are the treatment options available? So first generation is crizotinib, second generation are ceritinib, alectinib, brigatinib, and enzatinib, and third generation is lorlatinib, which is available for treatment of ALK positive non-small cell lung cancer. And nowadays fourth generation ALK inhibitors are in under development. So how these drugs were developed? So crizotinib was the first ALK inhibitors to be developed, and it was came into, it was a biomarker selected development process. Initially it was developed for MET mutation, but later on it was found to be active for ALK and ROS mutation. Therefore, it is a perfect example for drug development in biomarker selected population. So this is the Profile 01001 study, which is the proof of principle, which brought the proof of principle for crizotinib. And then later on other profile studies, that is Profile 1007, 1014, and Profile 1029, it established the role of crizotinib in ALK inhibitor in ALK positive non-small cell lung cancer, first in second line and later in first line treatment. So we can see in first line, crizotinib has a median PFS of 10.9 months, and in comparison to chemotherapy, which is 7 months, which is statistically significant, and overall response also is significantly better in comparison to chemotherapy. So then how these patients fail after crizotinib? Either they progress in CNS, that because crizotinib has very less CNS activity, you can say, or patient may develop some on-target or some off-target mutations. Or one of the example of on-target mutation is C120 G1202R mutation, which results in resistance to crizotinib. And so therefore, those patients progressing on crizotinib, there should be therefore the next generation ALK inhibitors came into picture. Those who are active against those on-target mutations which develop on those patients who are on crizotinib. So we can see in this table, the lorlatinib is which is the third generation ALK inhibitor. It is active in almost all the most of the known on-target mutations, and also the other next generation ALK inhibitors like ceritinib, alectinib, and brigatinib, they are also active in many of these on-target mutations. And so in this cross-trial comparison, we can see we have got second generation, we have got third generation, how to choose between them. So in this cross-trial comparison, we can see those patients who progressed on crizotinib, brigatinib doing better in comparison to brigatinib and alectinib in terms of overall response rate, and in terms of median PFS, these patients are doing better in comparison to ceritinib. And again, those patients who are having intracranial disease, who are having brain metastasis, in these patients also brigatinib and alectinib have got overall response, better overall response in comparison to those patients who are kept on ceritinib. So and coming to lorlatinib, again those patients who progressed on crizotinib and having G1202R mutation, in this patient, lorlatinib was found to having significant response in terms of extracranial or intracranial diseases. So lorlatinib also found to be having significant role in this group of population. So therefore, this next generation TKIs, they were tried in first generation, in first line as well. In Ascent 4 trial, ceritinib was found to be significantly found to be having better PFS of 16.6 months in comparison to 8.1 months of chemotherapy, and better overall response rate and hazard risk of 0.55 in first line setting. And in this slide, we can see next generation TKIs were compared to crizotinib because they were established as better in comparison to chemotherapy. So in this slide, J-ALEX trial, ALTA-1L trial, and the next EXALT-3 trial, it compared second generation TKIs to crizotinib, that is first generation TKI, and it found in terms of overall response and in terms of PFS, second generation TKI doing better in comparison to crizotinib. And third generation TKI, that is the lorlatinib, was tried against crizotinib in Crown trial, and it was found that found to be having hazard risk of 0.28 and overall response of 76% in comparison to crizotinib. So this is how they were established as first line treatment agents in case of ALK positive or metastatic lung cancer patients. And those patients who are having brain mets at presentation, we can see lorlatinib patients who are kept on lorlatinib are doing much better in comparison to others with hazard risk of 0.2. And in comparison to brigatinib, it is a cross trial comparison. I mean, in brigatinib, hazard risk is 0.24, and in alectinib, hazard risk is 0.37 in comparison to crizotinib. And so we can see, and coming to the overall survival, we can see here those patients who are on lorlatinib and when compared to crizotinib, these curves are not very much separating. Like the picture is not very much happy in comparison to the PFS picture that we saw in the previous slides, where the curves were very much separating. The overall survival curve is not like they are hugging to each other. Lorlatinib and crizotinib patients, they are like overall survival is similar. Hazard ratio is 0.72, and it is not statistically significant. And also we can see in the ALTA-1L trial, brigatinib and crizotinib, when they were compared, again the curves are hugging each other. That is, overall survival is not significantly different between the two agents, and hazard risk is 0.81, and again it is not statistically significant. So we can the reason for it is those patients who are on crizotinib, who progressed on crizotinib, they were later on given lorlatinib, or they were given the next generation TKIs. So therefore, overall survival curves are not separating. So how to decide in terms of overall survival, overall response rate, and in terms of PFS? Yes, your third generation and second generation TKI are scoring much better, but it does not transform to the overall survival, because those patients who are on crizotinib and progressing, and later on are given the option of next generation TKI, they are living as long as those patients who are started on lorlatinib. So in order to decide on the first line treatment, we have to take care of we will look into the toxicity profile as well. Alectinib has got toxicity, alectinib causes anemia, it causes myalgia, it causes raised bilirubin, it causes weight gain, and weight gain can be very difficult to manage in this case, and musculoskeletal pain and photosensitivity reaction. And likewise, those patients are on brigatinib, they can have raised creatine kinase, hypertension, so cardiac morbidity can happen, and raised lipase, and early onset pneumonitis can happen. And those who are on encertinib, they can have RAS, like RAS can be present in more than 70% of cases. Pruritus and pyrexia can also happen. And lorlatinib can have hypercholesterolemia, hypertriglyceridemia, weight gain is also an issue with lorlatinib. Peripheral neuropathy and cognitive effects, very important, cognitive effects. That is, it can cause depression. Those patients who are having neuropsychiatric disorders like depressed or something, I would like to think again before giving lorlatinib, because suicidal tendency is very common in patients who are having lorlatinib. So we have to take into account the side effect profiles as well, other than the overall response and PFS and OS. So in order to until now we have decided, we have discussed that those patients who are having bulky disease, high disease burden, we need overall higher overall response rate, and those are in those patients we can think of next generation TK is better to go for lorlatinib or alectinib or brigatinib. And if these are not available, we can go for ceritinib or crizotinib. And those who are having, we have to take into account the toxicity profile as well before deciding on the first line treatment option. Therefore, if you see the NCCN guideline, it suggests that those who are harboring an ALK rearrangement, so both alectinib, brigatinib, and lorlatinib, they are given the category 1 indication.
1 minute.
And ceritinib and crizotinib are also given category indication. And again, one thing to discuss many a times, the test result takes time to come. So those who are started on chemotherapy, they can either continue with chemotherapy and later on to change to ALK inhibitors, or they can stop chemotherapy and to give an option of ALK inhibitors. And same thing, those who are on second generation TKI, who then when they progress, they can be given the option of third generation lorlatinib. And again, the ESMO guidelines suggest the same. Alectinib, brigatinib, lorlatinib given the category 1A indication, and crizotinib and ceritinib given the category 1B indication. And when they progress, they should be given the option of third generation TKI, that is the lorlatinib. And this is our own data, where which we published in SHSC this year. And what we found that in first generation, there was no significant difference in median PFS between the different ALK inhibitors. But when we see the overall survival, those patients who had received any ALK inhibitors in any lines of treatment, they lived much longer in comparison to those patients who did not receive ALK inhibitors at all. So what we can conclude here, that is, we have a growing menu of ALK and RAS ALK and RAS TKIs that vary in chemistry, potency, and efficacy. And these patients live longer, and it will generate new questions on how best to optimize care for this patient. That is, those patients who are started on lorlatinib and are having complete metabolic response after 3 years, whether to continue or to discontinue So these questions are yet to be answered, and we lack head-to-head comparison between second and third generation TKIs. And most important to note here is to ensure that all KRAS inhibitors, like all KRAS, should be tested for all NSCLC patients. Thank you.
Thank you. Thank you so much. Well said and well covered, touched almost all the points. Now, we now move towards our next session, that is the second debate of the day. NGS in lung cancer liquid biopsy is acceptable. Yes would be from the speaker in favor would be Dr. Rupanita Biswal, pathologist from Bhubaneswar. And to negate or to refute her will be Dr. Subhashish Mohanty, pathologist from Bhubaneswar. And for expert opinion, the debate master shall be Dr. Padmaj S. Kulkarni, medical oncologist from Pune. Do we have all of them? I think there was some problem with Dr. Padmaj to join. So I would request Dr. Ghanshyam Biswas to kindly moderate this debate.
Yes, Romila. So
Yeah,
start the
thank
debate.
you. Yeah. Can we please start? Dr. Rupanita Biswal, we start with you.
Yes, ma'am.
Yeah.
Yeah.
So,
I hope it is visible.
Yeah, it is.
Okay. Good evening, everyone. So I would like to thank the organizer for having me as a part of this illustrious list. My topic is NGS in lung cancer liquid biopsy, whether it is acceptable or not, and I'll be speaking in favor of it. Sorry, just hold on a second. So the overview of the talk will be the diagnostic modalities in lung cancer, the indication of liquid biopsy, the scope, and the supporting evidence in favor of liquid biopsy and uses and advantages. In addition, the future of liquid biopsy. So the different diagnostic modalities which we use in lung cancers are will include our imaging modalities, antigen detection, tissue biopsy, as well as liquid biopsy. But having said that, we mostly prefer biopsy or tissue biopsy and a cytology sample for most of our cases and for molecular profiling. But when there is insufficient material or that material is not adequate for a molecular study, it is now a question whether we should go for a rebiopsy or to consider a liquid biopsy. Now, with this, the question of the evening is there a need of liquid biopsy? And the answer is why not? Because the several studies in the last decade have shown that the tumor DNA has shown equal and have captured equal number of mutation in comparison to the tissue biopsy. So what is a liquid biopsy means? It can be a cell-free DNA, it can be a tumor DNA, it can be exosomal DNA, RNA, and can also be a circulating tumor cells. It has several advantages over a standard biopsy in terms of it is a minimally invasive procedure, it is a quick procedure, and the turnaround time is very, very less. So what is the liquid biopsy? The scope for the liquid biopsy, it can be from early diagnosis to monitoring to precise treatment and prognosis. So the current NCCN guideline, what does it do? It mandates that the circulating tumor DNA should be tested only for the metastatic or advanced disease cases, but it is not accepted for stage 1, 2, 3. And also is not for the histologic diagnosis. But having said that, we should also understand that there are specific circumstances where still we can use liquid biopsy. For example, where the patient is not a candidate for an invasive procedure, or when there is insufficient tissue for the molecular analysis and for follow-up cases. So the liquid biopsy uses the same principle as tissue biopsy for the NGS purpose. It has an easier sampling process, faster result, and there can be a longitudinal monitoring. So now a pro and con debate mandates to talk about different literatures and different studies which will support my theory. So it not only captures as many mutations as the tissue biopsy, it also has captured 1/3 of cases where the tissue biopsy has failed. So many studies have shown that we should add circulating tumor DNA testing in addition to the tissue so that the detection rate can be increased. At the same time, disease progression can also be detected through liquid biopsy by serial monitoring. And suppose, for example, in tyrosine kinase inhibitor, if the patient developed resistance to it in case of EGFR mutation, the progression can be because of T790 mutation. So this can be also detected through liquid biopsy. At the same time, for the ALK, suppose a patient is not responding to brigatinib or a crizotinib, in case of ALK positive patient, the reason can be there can be a EML4 ALK-V3 fusion, or there can be a T53 mutant, which can be very well detected in the liquid biopsy. So for such cases, a serial monitoring through serial liquid biopsy is very, very helpful. A particular treatment for a particular patient is very, very important. It should not be the book language, or it cannot be a book therapy, what we are reading on a day-to-day basis. It should be a patient-centric treatment always. So in such cases, the liquid biopsy will help in identifying more single nucleotide variant and high allelic frequency variants. In the setting of immuno-oncology, what the circulating tumor DNA or the liquid biopsy has shown a good response in comparison to the CT response. And the circulating tumor DNA clearance has also shown a long-term benefit. In case of early diagnosis, the early diagnosis mandates a surgery followed by some kind of therapy, but the little amount of circulating tumor DNA, if it's present, can help us in identifying whether the patient is a candidate for a recurrence or will develop relapse after some time. So through liquid biopsy. To summarize, the liquid biopsy not only help in it is not only help in identifying the tumor heterogeneity, the different kind of mutation associated with the common driver mutation. It has a long list of other advantages as well, because it is minimally invasive. Is the cancer present or not? If it is, where it has spread, what is the genetic changes the tumor has right now? Will the treatment work or not? Whether the patient is going to treatment or not, that all can be known through liquid biopsy. But what does the future holds? The liquid biopsy, in addition, promises that with the advancement of the technology, it will also help in screening the treatment. Screening the patient for those who are not a patient now, but do have a potential for developing cancer in future. So for such cases, we will definitely use liquid biopsy, and we definitely need some robust data for this. Thank you.
Thank you. Dr. Subhashish Mohanty, sir.
Yes, good evening.
Yeah, good evening.
Am I audible?
Yes, sir. We can hear you, sir, but now again, your voice is lost.
So my PPT is with Sambit. Can he?
Sir, we are sharing the slides, sir. I hope the screen is visible.
So my topic is the disadvantages of liquid biopsy in non-small cell cancer. So before coming to the disadvantages, this non-small cell cancer has been identified with various genetic drivers for the last decade, and there is improvement for targetable therapy and immunotherapy. Next. So molecular testing has been a routine with various molecular drives like EGFR, BRAF, HER2-MET, and KRAS mutation with ALK and ROS mutation as per ESMO guidelines. Next. So what is the tissue? Tissue biopsy is the gold standard, and the tissue available is the smaller needle core biopsy. Over 40% of the patient of the lung cancer, they require rebiopsy to achieve a definitive tissue biopsy. And further, that complicates the issue that the failure of molecular characterization is around 30% of the cases which we send for molecular characterization. Next. So then comes the theory of the liquid biopsy. Because the tumor cells can be set through macromolecules in the bloodstream, both from primary and metastatic site, and assaying these samples are in the biological fluid are referred to as liquid biopsy. Next. So liquid biopsy is a minimally invasive technique and can be used can be used as an alternative to the tissue biopsy. Next. So what are the samples usually required for liquid biopsy? That can be from the body fluids, that can be from the peripheral blood, and these products of the liquid biopsy are the circulating tumor cells, circulating cell-free DNA, circulating tumor DNA, and circulating microRNA. But the most studied one is the circulating tumor DNA, which is used for somatic mutation, gene copy number variation, and gene rearrangement, and has a good concordance rate with the tissue analysis. Next. So this is a schematic presentation of the tissue biopsy versus liquid biopsy. Next. So cell-free DNA in the peripheral blood only contains, what are the limitations? The cell-free DNA in the peripheral blood contains very small fraction of circulating tumor DNA, with the bulk of remaining DNA originating from the hematopoietic cells in the blood. And these hematopoietic progenitor cells undergo somatic mutations, and this established a non-neoplastic clonal population of circulating cells known as clonal hematopoiesis of uncertain clinical potential. Next, that is called CHIP. So the mutations which are detected in the solid tumors like DNM23, T2, SX, JAK2 are also seen in the CHIP, and also T53 mutation and EGFR mutation, which has been cornerstone in lung carcinoma detection, has also been associated with the CHIP. Next. So CHIP clearly raises an issue in terms of clinical interpretation of liquid biopsy, as false positive rates can be potentially detected in large proportion of patients in wide array of genes. Next. So use of tumor DNA from molecular profiling is also suffering from the false negative results that due to the non-shaders, and this consists of patients with whom the known tumor driver mutation has been detected on tissue biopsy but not identified in the circulating tumor DNA. What is the cause? Next, what is the cause for this false negative result? Because this shedding of the tumor DNA is largely related to larger tumor, presence of necrosis of the tumor, and tumor vascularity. And the tumors thus lacking these features do not shed the circulating tumor DNA, and we cannot detect this in the liquid biopsy. Next. So moreover, this circulating tumor DNA doesn't help in the tumor grading and staging, and it only suggests the overall tumor burden. Also, in early tumor, in early diagnosis of lung cancer, where the treatment depends on the liquid biopsy, it cannot detect the circulating tumor DNA. Next. So there is a histological transformation of small cell carcinoma, which has been reported in 5 to 7% of EGFR TKI resistance cases, may not also be detected by this liquid biopsy platform. Next. And intra and intratumoral heterogeneity, which can be mitigated by circulating tumor DNA assays, may not reveal a proper, may have a different clonal process, that is in BRAF lung cancer, where there is BRAF mutation, and this BRAF mutation is seen in lung cancer, but the underdiagnosed cases of colorectal adenocarcinoma, multiple myeloma, melanoma, or even benign NAVI can have this, which may have overlapping of this situation. Next. So laboratory performing these assays need to be mindful of appropriate utilization of the risks of false positive and false negative, and the potential of over-interpretation in the clinical context. Next. So this precision medicine has revolutionized the patient care, allowing the personalized approach to the therapeutics such as tyrosine kinase inhibitors and immunotherapy. And these therapeutics often rely on genetic alteration of the tumor cells, and liquid biopsy offer a real-time and easy access. However, the liquid biopsy lack widespread clinical and commercial acceptation. Thank you.
Thank you. Dr. Rupanita, would you like to speak something?
I agree with Dr. Subhasis Mohanty sir for whatever he said, but still I would suggest that in cases where we are really facing, but there are cases and there are studies where really liquid biopsy is helpful. And in the previous workplace where I was working, they also use this liquid biopsy for disease monitoring and disease progression and for the treatment plan.
Yes, so Dr. Ghanshyam, this was your final comment.
So thank you, Rupanita, and thank you, Suashish, for considering our request. I think so there are lots of scope for liquid biopsy today, but the gold standard being a biopsy. So the pathologist means, so it was a biopsy, and liquid biopsy, though for many non-doctors or non-fraternity people, so still is a question that what is liquid biopsy. So I'll just tell an example of what has happened in last few weeks. So I had a patient who's a medical staff's mother, so almost debilitated condition. So she had a pleural effusion. So we did a cytology. So it came as adenocarcinoma. So we tried to do a bronchoscopy in a moribund patient, but this patient, we could take out some tissue, but it was inadequate. So since non-smoker female, so we did a run on NGS on the pleural fluid, and 10 days later it turned out to be exon 19, and this patient is on osimertinib. So within 2 weeks, the patient from wheelchair has just been moving around. So I have another patient of 82 years, Parkinson's. So thought of a stroke, got admitted. On evaluation, found to have a lung mass and a brain mets. And this patient is a VIP retired judge and very famous personality. So here we struggle to do or a high profile patient to do a biopsy. So we did a liquid biopsy. The report is yet to be there, but many times it has helped us. So paraffin is yet to be there, and probably liquid biopsy adds to that. If you look at the TEMPO study, so while you are looking at an NGS or a CGP, a broad-based CGP, so on adding a liquid biopsy or a blood sample, so you can get a 9% extra yield of something happening in the particular patient. So if you have an elderly lung cancer, you know that probably you are going to have those 40% of mutations. But if we are not picking up on a paraffin, so probably these are patients where you should chase a liquid biopsy, because as Dr. Rupanita said, so you might pick up those additional markers where this patient can be can go away without a cytotoxic. So these are certain situations where it is gone. So as she also said, so on a lung cancer patient who has progressed, so you know that somebody who is on a first generation or second generation anti-EGFR and progress, you know that 40, 50, 60% of these patients will pick up a T790. So that can very well pick up on a liquid biopsy. But there is a small chance this patient has developed a P53 mutations, and then probably you lose out a component of a small cell, and which you won't be doing, don't know unless and until you do a biopsy. So there are patients where you may not be able to do a PDL1 because PDL1 on a liquid biopsy is not yet standardized. So you need a tissue for a PDL1 for those squamous cell, those patients who are doesn't have a driver mutation. So I think there is a pros and cons of both of these. So at this moment, so both are going to complement each other. Like as a medical oncologist, so pathologists always complement with us, and that's how probably the paraffin or the routine biopsy, the gold standard is always there, and liquid biopsy is going to complement. Thank you so much.
Thank you. Beautifully concluded. And we quickly move towards our next session, the second panel discussion for the day. The topic being how to choose immunotherapy in advanced non-small cell lung cancer. It is to be the session, this panel discussion would be moderated by Dr. Chetan Deshmukh, medical oncologist from Pune. Over to you, sir.
Thank you very much.
Right? Yeah.
Just give me a minute. I'll share my screen, and I can see my panelists have already joined.
Chetanda, welcome. Chetan and
Thank you.
Padmaj are from the same hospital. So one is yet to finish the OPD, but Chetan has joined.
I can also see Dr. Dipti. Hello, Dr. Dipti.
Chetan, good evening.
Good to see you. Good evening. Good
Yeah.
evening. Really good to see you after a long time. Okay, so I was given the task of conducting a panel on immunotherapy for lung cancer, frontline setting. Most of us have been using immunotherapy. It's a well-established therapy in lung cancer. And to begin with, it was first used in the second line. And then now, since it's so effective, it has moved to first line, which is quite logical because such an effective therapy has to be given upfront. So, most of the studies which I have taken, some of them have been just representative studies. I did not take all studies, but I want to get a flavor from the panel as to how they choose their frontline therapy and how they choose immunotherapy in the frontline setting. So our discussion is limited to frontline setting only. So if I may start from you, Dr. Dipti, so you have a patient with advanced lung cancer without a driver mutation. So what is your preferred regime in your day-to-day practice? You have the options like PEM-carbo, you have PEM-carbo plus immunotherapy, or you use paclitaxel plus carboplatin. Still people believe that that is one of the gold standard treatments for lung cancer, plus or minus immunotherapy, plus or minus bevacizumab, or any chemotherapy with a low-dose immunotherapy. There is a lot of discussion happening in low-dose chemotherapy in other malignancies, not so much in lung cancer, but any takers for low-dose immunotherapy. So let me know your choices.
Good evening, everybody. Chetan, what you asked, because my patient will not having driver mutation. In this situation, definitely we will opt for immunotherapy because 35% of patients, they do not have driver mutation. In this situation, as we all of you know, that there is so many trials like Keynote 024 and this atezolizumab trial.
We'll come to that. We'll come to that. We'll come to that.
Yeah.
So right
Those
now,
trials are having PD-L1 more than 50% and very much expressive. Then definitely I will opt for single agent immunotherapy like pembrolizumab only and atezolizumab only. But if my patient having 1% to 49%, other trials I will choose. And here, in real world sense, I will say we are very much starting pembrolizumab carboplatin. If the patient is affordable, then we are adding immunotherapy like pembrolizumab, which is evident from Keynote 024.
So your basic regime remains PEM-carbo. You add immunotherapy to it based on your PD-L1. So suppose your patient is, may I ask Dr. Anita, so suppose your patient is PD-L1 negative. PD-L1 has been tested and patient is PD-L1 negative. Do you still consider frontline immunotherapy in these patients? Driver is of course negative.
Yeah, driver negative, PD-L1 is less than say 1% or it is 0. I will just continue chemotherapy because there is some data that they have used chemo plus immuno in the negative patients, but at this point of time, I will just restrict myself to pacli-carbo or pemetrexed carboplatin combination and not use the immunotherapy upfront if it is PD-L1 negative, CPS score low, tumor mutational burden low. I'll take all of them into consideration and also would like to see how that PD-L1 testing has been done. Okay, and take a decision. Basically.
Okay. Fine, I get your point. So we had a 62-year-old gentleman who was retired. He was a retired officer from a petroleum company. He had backache. So they did an MR which showed the cord compression due to vertebral lesions. They decompressed him. And then the histopath turned out to be a moderately differentiated adenocarcinoma, TTF1 and CK positive, possible primary in the lung, which was again confirmed on a PET scan. So, do you routinely do MRI brain for patients who have an extensive stage disease, Dr. Tathagat?
Thank you, Chetan.
Yes.
Yeah, I can. Can you hear me? Yeah.
Yes.
So, if the patient is so I have to give my background because I work in the NHS. So we have access to everything, but at the same time we are very protocol driven. So in this particular case, I would not be doing any MRI brain because this is already a metastatic patient. So if the patient is asymptomatic, then we can use actually immunotherapy with asymptomatic brain metastasis. So if the patient is fit, driver mutations are negative, then I would proceed to with the cord compression. Obviously, being a clinical oncologist, I will consider radiotherapy first with steroids, etc., and then consider systemic treatment. And depending on the performance status, if it's 0 or 1, and if the patient has no contraindications to immunotherapy, then I would consider combined chemoimmunotherapy. Can I just revert back one bit, which my predecessor said? I'm not trying to contradict anything. So I'm again telling from my own experience. Even with PDL1 TPS score of 0, if the patient is fit enough, in the NHS at the moment, we can use combined chemoimmunotherapy. The reason for that is obviously we know about the tumor heterogeneity, and obviously depending on where you have taken the biopsy, there is a possibility if it's glycosylated PDL1 protein, then that might be actually under-evaluated through all the assays we have right now.
Okay, thank you. That's an interesting perspective. So taking forward, if you can take the next question. So in NHS, what all molecular tests do you do? We have options of doing single gene testing, like only EGFR-ALK, which can be done on IHC also. We do limited panel, say about 15 genes, which includes most of the actionable ones. Or do you send it for the whole comprehensive profiling of, say, 500 or whatever number of genes you have?
So we do all the routine ones. So so we used to do NGS. Now we are using the Cadillac Catrice. I'm not very averse with what exactly the difference between the NGS panel and the Cadillac Catrice. But so basically EGFR, ALK, ROS, BRAF, MET, RET, NTRAC, everything is done. On top of that, okay, obviously KRAS is another thing which I'm missing. So everything is done in one go. We do not do any NGS panel or Cadillac for patients who are heavy smokers and squamous cell cancers. We do it for all non-squamous. And obviously the PDL1 is done separately. Now we have this genomic hubs. So we have got 2 hubs. I work in Sheffield, and there is the main hub is in Newcastle. So we do reflective testing actually. So in majority of the centers, or at least we send it from the MDT, where if the PS, if let's say patient performance status is 3/4 is inpatient, then we won't be able to do it. We won't be doing it because it doesn't make sense to do that in patient who is not fit for systemic treatment. But we do it upfront for everyone else.
Fine. So this gentleman underwent EGFR ALK-ROS testing, no RAS, RAF, MET mutation, HER2 negative, PDL1 negative. He had recovered fully after surgery. We also offered him radiation. Otherwise, good performance status. Finance is not a problem. Dr. Prashant Parida, what
Yes,
are
sir.
your options? What are your options for? So we have a. We heard Dr. Dipti said that she would use immunotherapy upfront. Dr. Anita is not going to use immunotherapy if the PDL1 is 0 and TMB and all other parameters are not favorable. She's not going to use immunotherapy. She's going to stick to good old chemotherapy. Dr. Tathagat from the NHS says that, well, it is approved there, so he's going to use it. What about you?
So this elderly gentleman having most of the actionable biomarkers are negative. So
elderly 62 elderly mat bolo.
Yeah, okay.
So
even though his PDL1 negative, his performance status is good, and also you have told finance is not a problem, and most of the guidelines now in PDL negative subgroup also IO drugs can be combined with platinum doublet. So because there is a option, patient and relatives, the family members should be counseled regarding combining IO with the platinum doublet and the advantage. So all these things should be discussed with the patient party, and if they are they really agree, then I will definitely combine some IO drugs like pembrolizumab to platinum pemetrexed definitely.
Yeah, I think that's a fair plan. So that is what we also would do. That is what is approved by the NCCN, that you need to give some PDL1 or PD1 inhibitor along with your regular chemotherapy, if feasible. Of course, all other things, and that is largely based on, this was probably one of the studies which established the role of pembrolizumab in metastatic non-small cell lung cancer. Remember, in this these patients were enrolled irrespective of PDL1 status, but 30% of these patients had a PDL1 less than 1. And of course, their driver mutation had to be negative. I'm sure all of us have gone through this schema, 2:1 randomization between pem-carbo versus placebo plus pem-carbo, and then patients were continued on respective maintenance, either pemetrexed placebo or pemetrexed pembro. There was a fair amount of crossover as well. Some patients did crossover to pembrolizumab on progression. Nevertheless, the overall survival in the intent to treat population, this is the 5-year update, the curves continue to remain separate at the end of 5 years. So there's still a difference of about 8 units, and the hazard ratio is 0.6. Dr. Anita, not good enough for you?
Yes, it looks, but it is too early to make a practice changing. Yes, data is promising, but too early to make practice change.
Okay, because it was irrespective of PDL1. See, the forest plot shows that the hazard ratio favor both pembrolizumab combination in both, whether it was PDL1 less than 1, more than 1. So probably, yeah, I understand that financial issues are, of course, going to be a major deciding factor. Most of us in our practice do not use upfront pembrolizumab for obvious reasons, that it's just not feasible. But once it becomes more accessible, I think we will, by that time, we'll also have a fair amount of data generated, and we will probably, hopefully, use the same combination. The best part was those patients who had remained alive without therapy, without subsequent therapy. This is the population who completed 35 cycles, and in this 5-year update, the number is small, only 57 patients. But of these, 23 patients have remained alive without progressive disease or without subsequent therapy. So technically, at the end of 5 years, if they don't need any therapy, they are disease-free and treatment-free, they are cured. So this is something very interesting which we have never seen in lung cancer. So definitely heartening. Again, the same thing happened with squamous carcinoma as well. The 189 study was with adenocarcinoma. This study was with squamous carcinoma. Again, pembrolizumab, carbotaxol, and versus placebo plus carbotaxol. Again, almost doubling of 5-year overall survival. So, Dr. Dipti, if you have a patient of squamous carcinoma, do you look at it differently from the immunotherapy? Do you try to push immunotherapy a little earlier?
You see, because whatever Anita told, due to this financial problem, we are most of the time unable to start immunotherapy, even though it is indicated in several trials. But in terms of squamous cell cancer, there is no driver mutation, and we have to rely upon immunotherapy. The data will be much mature. Then definitely we will opt for immunotherapy, like Keynote 407 trial you highlighted now. That is chemotherapy and immunotherapy combination. And here is we are seeing the graph also separates. But it requires more data to be much enriched, to be more confident about this immunotherapy use.
Okay, just to complete the loop, about update about this patient, he did not receive immunotherapy. He continued pem-carbo. He had a fair response, but over a period of time, he developed progressive disease, and then he opted for single-agent nivolumab. After 4 courses, there was no response. In fact, there was a slight progression as well. So we did a repeat biopsy, and that showed a red fusion. So, Dr. Tathagat, you seem to have a fair experience with molecular testing compared to all of us. So, if you have this kind of a test done upfront, and if you have a RAS mutation or a RAF mutation, you have a red fusion or a MET, does that change your frontline therapy? or frontline plan? You said your frontline plan for non-driver mutation is chemo plus immuno.
Yeah. So yes, you're right. So other than NTRK, so the TKIs for NTRK and KRAS are actually approved to be used in the second line only. Other than those two, if this patient would have a RET mutation up front, then probably what I would have done is post spinal fixation, give some radiotherapy to the spine, and then go on to start the tyrosine kinase inhibitor in the first line.
For RET, which tyrosine kinase inhibitor do you prefer?
So tepotinib is approved for RET, isn't it? So tepotinib is used. I mean, I think the diagnosis of RET mutation has been, I cover a small DGH actually. I'm based in Sheffield. So I have had one RET mutation patient so far. And with that patient, actually my personal experience is, so patient had high creatinine straight away after first or second cycle. So I cut down the dose, so stepped down to the lowest dose, which I think is about 125 milligram of tepotinib. And the patient has completed actually 2.5 years. And what actually happens, this patient has 2 weeks of tepotinib and then the creatinine goes off. So she's very worried about her GFR falling below 50. So I give her a break for a week or two. And she has had complete response in the chest. The effusion hasn't recurred. So I would definitely use if there is a targetable mutation in this patient, the RET mutation, then I'll definitely go for TKI and then keep the other systemic treatment as second line.
Fair enough. So,
Chetan sir, I want to interrupt. So this is RET mutation. It is cell-percatinib or prasaltinib. So not it is not met.
Tepotinib. Yeah, it is not met. It is RET. So
okay, sorry, I confused with MET then. Sorry, it's a RET. Yeah. So cell-percatinib is
so basically
actually
TKI. I got it. Yeah. The principle was TKI. Okay. So most of our panelists expressed inability to use immunotherapy for cost reasons, and which is a very fair reason. So how about low-dose immunotherapy? A lot of people have been doing low-dose immunotherapy in head and neck cancer. Dr. Vijay published a great paper, and there's a lot of discussion happening on that paper. So, Dr. Prashant, have you ever thought of using low-dose immunotherapy when the patient has financial issues? Your PEM carbo is already covered by some government scheme or something. Have you ever done this thing in practice?
Yes. So I have a lot of head and neck patients with low-dose immunotherapy.
Hold on. We are talking about lung.
Yes. So I have started with 40 milligram because the nivolumab 40 milligram low dose I have started only 2 to 3 patients. So I have not evaluated them, but based upon the head and neck data, even in head and neck, though the particles are given 20 milligram, I am giving them 40 milligram because the vial contains only 40 milligram. Yes. So I have started 40 milligram along with some oral metronomic therapy. But I am not only few patients I have started recently.
Okay. Anybody else in the panel? Dr. Dipti, Dr. Anita, your experience with low-dose immuno?
No, actually, Chetan, that is now we are very much confident to use with head and neck cancer, but till yet we are not having sufficient data regarding low-dose immunotherapy in lung cancer. I think we have not started, but if the data will be sufficient strong, then it may be used because it looks amenable and very much friendly to the patients.
Honestly, data will not come from any big randomized company-sponsored trial. It will have to be done by some investigator-initiated study, which was done. Actually, this is a paper from Singapore. Interesting paper. They have used low-dose pembrolizumab in the treatment of advanced NSCLC. They have tried 2 doses, 100 milligram versus 200 milligram. Small study, only 114 patients. 65 received 100 milligram, 49 received 200 milligram, and they found no major difference in the PFS and OS. Whether you give it single agent, whether you give it in combination with chemotherapy, there's hardly any difference. You see the survival curves, they are almost overlapping each other. No great difference. And the grade 3 or above toxicities are also more or less the similar. So whether you use 200 or 100, probably it is giving the same amount of benefit. I don't think we'll have any big pharmaceutical company taking up this kind of data. It will have to come from investigators like us. Anyway, let's move on. So, if you are finding immunotherapy very effective, why not use 2 in place of 1?
Chetan, may I ask you one question?
Yeah, please.
This low dose immunotherapy, whether there is PD-L1 status has been evaluated or it is unselected?
Yes. I can share the paper with you. After the meeting, I'll share the paper with you. You can go through the paper, but it's just a food for thought. I don't say that it's data. It's just food for thought that if somebody is using low dose pembrolizumab or half dose pembrolizumab, probably even lower dose will work. We never know. Anyway, so Dr. Tathagat, coming back to you, doublet chemotherapy, doublet immunotherapy. How about you use a lot of immunotherapy upfront? How about doublet immunotherapy?
Chetan, I'll just again add something to the last question very quickly. So already in the UK, we are doing the refine lung trial where one thing is obviously reducing the dose, but the second thing is extending the duration. So reducing the frequency of administration. So refine is already looking at giving 3 weekly, 6 weekly versus 12 weekly immunotherapy. And it's not only limited to lung, it's multiple solid tumors. The second, so getting back to what you were asking me, the doublet immunotherapy, are you talking about 2 immunotherapy treatment drugs, or are you talking about
Ipi-Nivo?
Ipi-Nivo, in my experience, I have only used it for first line in mesothelioma. So I have very little experience of using doublet immunotherapy in these patients. So I would probably prefer continuing if maintenance or as a second line treatment with single agent immunotherapy. And yes, checkmate 227, obviously we wait to get to know what exactly it is. But the other thing with checkmate 227 is that actually PD-L1 score, it showed that PD-L1 score actually was not very essential in deciding whether it responded to immunotherapy or not.
True.
That's all I would say. Yeah.
Yes. Anybody else in the panel? Dr. Anita, any experience with doublet chemo, especially doublet immuno, especially if a patient is unable to tolerate regular chemotherapy?
I have not used, I have used nivolumab low dose, okay, but not the nivolumab ipilimumab combination. I think it's about a year which is now marketed, but not use the combination. But whatever the literature says, the addition of the ipilimumab to nivolumab has not increased this toxicity. Okay,
yes,
efficacy
definitely.
Yes, efficacy is increased, and this is the standard of care of some many indication. One is first line non-small cell. It is also approved drug in melanoma. Okay.
Yes.
Ipilimumab.
In renal cell in the renal cell cancer as well.
Right, in renal cell. And if you see with all the PDL higher, greater than 1 and lesser than 1, both the nivo ipilimumab has initiated good 5 years response, and it's just showing promising. But I have to use it, and many of us do need to use it because the 2 immunotherapy drugs may not be feasible in a country like India.
Dr. Shravani, I see that you've raised your hand. Please go ahead. Please ask your question. Dr. Shravani, you've raised your hand.
Anita, I think you need to unmute her.
Just a second, ma'am.
Yeah.
Is she there, or should we move on to the next?
Sir, I would just like to make one comment. This is Dr. Saurabh here.
Yes.
So basically, yes, this low dose nivolumab we have used for a couple of patients in squamous cell carcinomas as a maintenance therapy post paclitaxel carboplatin. And patients have done okay actually. So usually in squamous there is no maintenance strategy as such.
Correct.
So nivolumab low dose has worked and had some stable disease and all for some time.
Correct. So there is a lot of low dose immuno in the lung happening. Probably we just need to put together our data and publish it. That is how we'll probably work out this thing. Fine. So, let's move on. I don't see any, we have only 5 minutes or so. So immunotherapy with driver mutation. From the first slide onwards, I have been saying that non-driver mutation. Suppose we have a driver mutation. Are you comfortable in using immunotherapy? Dr. Dipti.
The patient is having driver mutation. I'm not comfortable to use immunotherapy because.
So it's always a no.
Yeah, that is no, because
always,
we have to use
Dr. Prashant, Dr. Anita, your thoughts?
Yeah, driver mutation first line should be the mutation. Okay, because it is the dominant, very dominant therapy. And then if the mutation therapy fails, okay, then we can later on combine with immunotherapy. But definitely immunotherapy is not the first line.
And also, sir, Dr. Prashant here.
Yes,
so using immunotherapy in any driver mutation positive cases, there are a lot of disadvantages also. The response rate will be low, and because of the long-term effect, because the effect will persist for a longer period of time. So after immunotherapy will give the targeted therapy or driver drug, then there will be a lot of toxicities. So even prognosis wise, those patients, there will be a lot of morbidity later on. Therefore, it should be avoided in front line.
Okay. So, Dr. Tathagat, I want your opinion on this study. This is the Empower 150 study. Patients were randomized to Atizo plus Carbopacli-Bev, and all these patients were irrespective of, they also had driver mutations. Atizo plus Pacli-Carbo-Bev. What is the UK verdict on this study?
So at the moment, this is obviously the 4-drug ABCP is approved for use. It's very rarely used for obvious reasons. NHS, obviously, we try to keep the cost as little as possible. It's all public funded. This is certainly something which you use for patients who have driver mutation, particularly like ALK and EGFR, as the second line treatment. So then there are some of my colleagues who have used it for particularly patients with upfront liver metastasis. So this trial, obviously, when they did the subgroup analysis, I think it showed patients with EGFR mutation as well as the patients with upfront liver metastasis. There are slightly added benefit. This is the standard treatment for patients who have progressed following first line anti-ALK and anti-EGFR mutation treatment. That's basically what we would use it for. It's accepted, but it's a second line post TKIs.
Yeah, the study demography showed that the number of such patients who had a driver mutation is not very large. About less than say 15% or probably around that. So most of the patients were not EGFR AL cross mutated. Majority, though they say that they've taken all, they have the number is really very, very small. So driving any conclusion out of such small number of patients may or may not be a good idea. Of course, the overall survival, there is some difference in the overall survival, but the p-value is significant. But I don't know. I think most of our panelists are comfortable using a driver-based therapy rather than immunotherapy in the frontline setting. So what about chemotherapy ineligible patients? Patient has some creat-related issue. Let us put it as platinum ineligible. If you have a patient who has some comorbidity which doesn't allow you to use the standard doublet, platinum doublet chemotherapy. Dr. Prashant, what is your plan for such patients?
So if performance status is poor, for example, PS3-4, those single, if PD-L1 is positive,
PS is good, but the creat is 4. PS is good. PS is 1, but the creat is 4.
Okay. So IO drug single agent, if PD-L1 level is more than 50%, but because PD-L1 level, it is a continuous variable. It is not that someone having 48% PD-L1 and someone has having 52% PD-L1. 52% can be given as single agent, 42% cannot given. So in my opinion, it is a continuous variable. 48%, 52% single agent IO may work. And if someone has comorbidities like this, you can advise someone with low PDL level with single agent IO also. And as we have discussed, low dose IO is an option, and single agent chemotherapies like gemcitabine, taxane, that can be advised also in addition to IO. So these are the options can be used in this setting.
Okay, I just wanted, this was actually my last part of the talk, because I just wanted to draw your attention to this rather interesting study, first line Atizo monotherapy versus single agent chemotherapy. The chemotherapy is a non-platinum one, gemcitabine or vinorelbine. Dr. Kumar Prabhash is also one of the authors for this study. And they have shown that there is slight benefit of using atezolizumab over regular chemotherapy. But again, such patients are going to be far and few, and using atezo in all of these patients may not be financially or practically feasible. I think this is my last slide. I'm sorry, I've just exceeded my time. Thank you for
that's absolutely fine. Absolutely
such an
fine.
interactive session. It was a nice, wonderful discussion. Talking to you was great. Thank you very much.
Thank you very much, sir. So it was really well moderated. So we all had good.
I am Dr. Dipti. I can put one word.
Yeah, please, ma'am.
I want to congratulate Dr. Tathagat because he is from our institute, and we have not since many days we have not met. And I very much congratulate him in this webinar. I have already having this opportunity to congratulate him.
Thank you, madam. Thank you very much.
Thank you. That's
Thank
nice.
you, Ghanshyam, also to have this opportunity to us.
Wonderful.
Thank you, Dr. Ghanshyam. Thank you very much.
Thank you.
Thank you so much. Thank you so much. Now we proceed towards our next talk, advanced EGFR mutated non-small cell lung cancer, evidence-based review of targeted therapies. It is to be presented by Dr. Ghanshyam Biswas. Sir, please take over. Thanks.
Please allow screen sharing.
You can share now, sir.
Is seen? Is okay?
Yeah, it is visible, sir. Properly visible. Yeah.
So advanced EGFR mutation non-small cell evidence-based review of targeted therapies. So lung cancer is considered as the poster boy in a personalized medicine. So, and today's new poster girl is carcinoma endometrium, because lots of things are happening in endometrial space. So as a poster boy, so the lung cancer, the genomic profile, so all road leads to an NGS, and those who have dealt with NGS, so they call it as a white elephant. So this is a recent slide, so maybe less than a week back. So the NSCLC biomarker story in a nutshell. So the first on the extreme left is a mandatory and highly recommended molecular markers. In between is an emerging molecular biomarkers, and at the extreme rate is right is an exploratory and potential molecular biomarkers. So in the mandatory, you will have a SCAT1 and SCAT2, and where we see ALK, BRAF, EGFR, MET, all these, including the most common mutations in EGFR and also certain uncommon, including T790. And the whole immunotherapy space, you can see in the middle group for the predictive markers of immunotherapy, and also in the extreme right. So more than 50% of stage 4 NSCLC have biomarkers. And the predictive biomarkers are indicative of a therapeutic efficacy because there is an interaction between the biomarker and the therapy on a patient outcome. Prognostic biomarkers are indicative of a patient survival independent of treatment received because the biomarker is an indicator of the innate tumor aggressiveness. So normally, most of our medical oncology colleagues resort to, we have moved from 3 gene to 5 gene, now 12 gene, plus a PDL1. And these are all ALK rearrangements, EGFR mutations, and slowly we have targeted therapies for each of these. And we have had a beautiful talk for ALK by Lalatendu, and now we'll focus on the EGFR space. So as a Asian, so probably, unfortunately, somebody of us gets a lung cancer. So 30 to 40% of an Asians will have EGFR mutation as a driver one, is compared to Caucasians who probably express less than 20%. And it is said that it is very difficult to kill a Japanese with a lung cancer stage 4 because probably they have the highest of EGFR mutations. So the EGFR driver mutations in lung cancer spans from exon 18, 19, 20, and 21. And so mutation associated with drug sensitivity. So there are different sites of the EGFR binding. So if you see the EGFR mutations, so the most commons are exon 19 and exon 21, especially the late 5 beta, almost equally distributed. And 10 to 12% are rare mutations where this whole cohort, which are mentioned here, can come. So one of them is an exon 20 insertion for which there is a drug available today. So from an option from none to many, so options of a first line treatment in a metastatic EGFR mutation NSCLC. On the left hand side, you have a first generation gefitinib erlotinib, second generation afatinib and dacomitinib, and the third generation is osimertinib. So these drugs can be used alone. On the right hand side, so you're combining erlotinib with bevacizumab, the NEG study. You're combining erlotinib with ramucirumab, the Lilly study, that is Relay, the gefitinib and chemo, which is from the Tata, from Kumar Pravas and Vanita, and the recent kid on the block is the osimertinib plus chemotherapy, which is a FLAURA2. So if you look at the first line EGFR TKIs in the EGFR mutation in NSCLC, the upper half is for the first generation, then Lux and Archer for the second generation, and the FLAURA has been in the third generation. So in nutshell, so all of these drugs had an overall response rate. They had a median PFS benefit, but till some time back, we did not have a significant OS except few of these studies. So if you look at the potential gain in the PFS from IPUS to FLAURA, so it has been a phenomenal. So almost doubling of a PFS in a metastatic non-small cell EGFR mutated from 9.5 has jumped on almost to 19 months. So from first generation, there was improvement in the second generation and then in the third generation. So in nutshell, if you look at the status of first line EGFR TKI, so you have a huge responses. Within 15 days, 20 days, the patient responds. You have a huge PFS. Well, till some time back, before the FLAURA, so it did not have a potential or a mammoth OS benefit. So now look at the first line TKI combinations. So Ullas says the KN regimen. So that is Kumar Pravas and Vanita Narona. So pemetrexed, carboplatin, gefitinib, which is practically feasible in our patients if they are young enough, good organ status, so they can be benefited. Then the NEG study, then the Relay, and the NEG 026. And now the FLAURA2 is the new poster boy for combination of chemotherapy and a third generation. So we had trials of first generation gefitinib and erlotinib. Now we have a third generation. So we don't have a combination of chemotherapy and a second generation EGFR TKI. So the key factors, how you are going to choose your TKI in a first line, so depends upon sequencing makes survival. And we should understand that not all TKIs are equal. You look at the efficacy, the adverse event profile of the drugs, patients' comorbidities, and drug-to-drug interactions. And we should not forget that 1/4 of our patients of EGFR will have a baseline CNS involvement, which may not be symptomatic. And another 20% gets added while you are on this treatment. So it means in a lifetime of EGFR mutated NSCLC, 50% of these patients will have some amount of brain involvement. So that's why CNS involvement at baseline, whether symptomatic, asymptomatic, also is an important factor. So the big questions are all EGFR mutations same? No. Is deletion 19 and L858R, which are common EGFR mutations, are they same? No. So is it a time for a tailor-made approach? Yes, from 18 to 21, so all are different. So now focus on the common ones. So exon 19 deletion and exon 21 substitution, that L858R. So are we going the way we treat a metastatic CRC? Because we understand that left-sided colorectal cancer is good genomically as compared to a right-sided metastatic CRC. So in this way, so 19 deletion is just like a left-sided colorectal, and 21 L858 is just like a right-sided colorectal cancers. So you can better remember. So the clinical characteristic is that right side L858R are elderly patients with lipidic growth and lymph node metastasis is uncommon here. Whereas deletion 19 comes in a younger age group and they are mainly a papillary type. So malignant pleural effusion much more in the L858R co-mutation rates. So more than two-thirds of the patients will have co-mutations besides the EGFR, and that's the reason that they have a poor responses as compared to 19 deletion. T790 mutations after exposing to first generation, second generation is much more in the deletion 19 as compared to L858R. Sensitivity to EGFR TKI is low in the L858R, and that makes it that 19 deletion and L858 are different biological characters, clinical features, and prognostically. So this is how the osimertinib works. So it inhibition of EGFR mutations, 19 deletion L858, inhibition of T790, and lower activity against the wild type EGFR. So it can cross the blood-brain barrier, and that's the reason that it has good amount of CNS activity. So if you look at the indirect meta-analysis, which was 6 studies, around 1,400 patients. So if you exon 19 deletions were associated with a longer PFS as compared to L858R. So this indirect meta-analysis showed that significant reduced risk of disease progression for exon 19 deletion. If you look at direct meta-analysis of 7 studies, around 550 patients, this also showed that exon 19 deletion is a good as compared to L858R. So if we see the whole of first line, that is Uratec, if you see the second generation Lux Lung and the Archer from dacometinib and the Flora. So in every trial you see, so exon 19 is doing good, but on the lower side extreme left, so the maximum survival for a exon 21 with osimertinib even was 14.4 months. So if we see in exon 21 L858R, the median PFS did not exceed 14.4 months with the available TKI. So be it a first generation, be it a second generation, be it a third generation osimertinib. So we were stuck at 14 months in the L858R even with osimertinib. Otherwise, exon 19 patients were doing good. So came the relay. So combining Cyramza, that is anti-VEGF, with erlotinib, you can see exon 19 and exon 21. So the difference was not much. So moving from 14.4 months to now 19.4 months. So if you come to the summary of Flora, the osimertinib became a new standard of care, the third generation first line therapy. It showed a PFS improvement. It showed a overall response rate improvement. And important is that finally, so we got an OS benefit as compared to a standard of care. So hazards of 0.799, preservation of PFS, and the good part was that it is very well tolerated drug. So no much of side effects, and the CNS activity was huge, and that's how osimertinib became the poster drug for such a bad disease. So both systemic and CNS clinical benefit were observed with osimertinib. Then came Flora 2. So combining osimertinib with chemotherapy, the primary endpoint was PFS and rest was secondary endpoint. So Flora 2 has just been published, and you can see that again a huge PFS difference with as compared to osimertinib alone. So 9.99 months additional benefit. And if you see the BICR, so blinded independent central review, so the difference is much more than almost 10 months. So the PFS2 and OS data are immature, but this combination, though benefit, but toxicity was a bit more. So if you see the new NCCN 2024, so if you see the EGFR mutation discovered, so preferred is osimertinib, other recommended, so FLAURA2, that is osimertinib, pemetrexed, has been a category 1 like olutasidenib, afatinib, gefitinib, dacomitinib. So these have been other recommended category.
2 minutes more.
So immunotherapy in EGFR mutated patients, so while Chaitanya discussed, so if you have a high PD-L1, but if you have driver mutation, just stay away from immunotherapy, put them on anti-EGFR, unless and until down the lane, second line, third, beyond third line, probably you will have some role. So otherwise, so even with a high PD-L1, 100% PD-L1, but if you have a EGFR or an ALK, don't put these patients on anti-EGFR. So coming to an uncommon mutations, so 90% are common or a classical or typical mutation. 10% are considered as uncommon or atypical mutations that can happen from 18 to 21. So there is something called compound EGFR mutations. So that can be 2 classical or 2 uncommon or 1 classical and 1 uncommon. So these are frequencies of uncommon mutations that can be seen in exon 18, exon 19, exon 20, and exon 21. So if you see these curves, uncommon versus common mutations, the survival is huge different. So it means uncommon mutations patients are doing bad. If you see the drug sensitivity, so you cannot throw away the first generation gefitinib olutasidenib. If you see the IC50 for certain exon 18, like deletion 18, or these are certain mentioned, so still gefitinib olutasidenib is good. If you see IC50 less than 10 is in favor of afatinib.
30 seconds.
Yeah, so please give me 1 minute. So median PFS EGFR TK has been repeatedly shown to be shorter for in uncommon versus common. And if you see first generation, as I said, still there are patients, if you pick up your mutations, so there are patients who are going to be benefited in uncommon mutations with the first generation TKI. Otherwise, for a common mutations, so first generation TKI without any combinations with bevacizumab or a Cyramza or chemotherapy is almost out. So third generation, again, so osimertinib, and has shown a benefit even in a uncommon mutations. Afatinib is probably the drug of choice in an uncommon mutations. So coming to exon 20, so there are drugs like pozotinib and mobocertinib, but mobocertinib has been taken out. There's a bispecific antibody, which is tremendously costly. Amivantamab is there. And so the pozotinib has also shown a response. Amivantamab for exon 20 insertion, so that is the drug of choice, but many patients may not be able to afford from the Johnson & Johnson. The snapshot is that exon 19 is the good boy, so here osimertinib is the choice. Exon 21, so difficult to treat EGFR, so probably relay or osimertinib. Uncommon mutation, certain patients will be benefited with afatinib, osimertinib, and even the first generation TKI. Exon 20 are usually refractory, so the role of pozotinib and amivantamab. So molecular tumor board is the way forward for such complex mutations. And ultimately, we are talking about lung cancer where prevention is better than cure. Thank you so much. Sorry, Romila, for taking 1 minute.
No, sir, that's fine. That's fine. Thank you, sir. Now we move towards our next session by Dr. Prashant Kumar Parida, medical oncologist from Bhubaneswar. He'll speak about management of MET-driven advanced non-small cell lung cancer. Dr. Prashant, we have you with us, right? Yeah, you're visible.
Thank you, Ramila.
Thank you.
Thank you, Vishwas Bhai, for organizing such a wonderful CME. And
Anita, allow slide sharing. Yeah.
Now my slides are visible?
Yes, sir. Yeah, there.
So a lot of discussion has been done about the actionable driver mutation as well as IO drugs. So I will discuss one of the actionable driver, that is MET exon protein skipping mutation. So evolution of therapy in advanced non-small cell lung carcinoma. Previously, we are treating all of them similarly with platinum doublet, gradually histological breakdown, with histological based cytotoxic therapies, then several molecular subtypes, EGFR, cross, BRAF, like this, and a lot of actionable driver mutation has been discovered, and those can be targeted. Some of them are in pipeline, and IO drugs based upon the PDL1, the only important biomarkers available. Like we can use IO drugs. So nowadays we are individualizing the treatment based upon these biomarkers as well as PDL1 level. So in nutshell, this one slide, you can see almost all the actionable driver mutation in almost 50% of advanced non-small cell lung carcinoma, non-squamous. You can have some targets that can be potentially targetable with some of the approved drugs. It has been discussed by previous speakers. So whenever a advanced non-small cell lung carcinoma patient comes to you, we should go for the molecular testing, at least with a broad molecular panel, preferably by NGS, so that most of the approved therapies against the biomarkers can be tested. So molecular testing is paramount importance in identifying patients with MET exon 13 also. It is seen in almost 3 to 4% of patients. And in sarcomatid carcinoma, one particular thing we have to remember is in sarcomatid carcinoma, it's MET exon 13 is almost in 20 to 30% of cases you can get this mutation in sarcomatid variant. So in NCCN guidelines, same thing in non-small cell lung carcinoma, we should go for a broad molecular profiling, and MET exon 13 is one of them. So, but though tissue is the gold standard for testing most of the biomarkers as well as MET exon 13, but some of the patients, this tissue biopsy is not possible or suitable due to several factors like comorbidities or frailty of the patient. So liquid biopsy is a viable alternative or viable option there. You can do liquid biopsy. And liquid biopsy, it is highly accessible, non-invasive, patient compliance is better, and risk of complication is almost nil. Sensitivity is also high, though it is slightly less than tissue biopsy, but sensitivity is high, and it is suitable for almost all patients. And one of the advantages of doing liquid biopsy, as Bishwas Bhai has discussed, is it will take care of the tumor heterogeneity, as well as you can pick up some another mutation, almost 9 to 10% of cases, further mutation. So it will add on to the tissue biopsy if possible. So this is a retrospective multi-center analysis of overall survival though it is they have taken only 34% in overall survival and in MET exon 14 skipping mutation subgroup, and you can see when a TKI was compared with chemotherapy, there was improvement in survival. So median overall survival was significantly longer with MET TKI compared with the chemotherapy, almost 3 times, 8 months versus 24 months. Therefore, in almost every patient, you should go for a biomarker testing. And one thing we have already discussed, whether someone with PDL1 positive or high PDL, because this MET exon 14 skipping non-small cell lung carcinoma, they are likely to have high PDL1 positivity. So despite this, by a MET exon TKI, tipotinib has shown a real world PFS advantage. So even though PDL1 is very high, more than 50%, the IO drugs, the response is poor, and also when it has been compared with single agent IO, PFS is much higher than the IO drug as a single agent or with chemotherapy. And also you will see the response rate. Response rate is low with IO drug 17% versus 67% in the MET inhibitor arm. And you will see the PFS and median overall survival also significantly better in MET TKI group. So based upon that, most of the guidelines, including NCCN and ESMO guidelines, they have recommended patients with MET exon 14 skipping advanced non-small cell lung carcinoma. The preferred line of therapy are TKIs, tepotinib and capmatinib. These two are the preferred frontline options, and in certain circumstances you can use crizotinib also, but tepotinib and capmatinib are preferred by almost all the guidelines. And NCCN guideline you can see if discovered before starting frontline, preferred options are capmatinib and tepotinib. If you have started some systemic therapy, then after progression also you can use these drugs. So based upon this Vision trial, which is the landmark trial of tepotinib, it is approved by most of the guidelines. So it is one of the largest study, including more than 300 patients of metastatic non-small cell lung carcinoma, and almost have included median age of patients are more than 70. So almost all of them are elderly patients, and more importantly, more than 30% of patients are from our Asian subcontinent. So that is very important, and it is one of the first clinical trial. They have included prospectively enroll both liquid and tissue biopsy. So they have taken both, and they have taken both treatment naive as well as previously treated patients, and 18% of these patients have brain metastasis. So this is the study design. It is a singular phase 2 trial of advanced non-small cell lung carcinoma with MET exon 14 mutation, and they have taken two cohorts. Cohort A is primary analysis, cohort C is confirmatory analysis, and they have combined analyzed. So they have used tepotinib 450 milligram once daily, and they have analyzed treatment naive as well as separately treatment previously treated patient. Primary endpoint as overall response rate, secondary endpoint DOR, OS, PFS, and safety analysis. So, as we have discussed, they have taken both liquid and tissue biopsy. 42% of patients they have done only tissue, and 36% only liquid, and in 21% of cases they have done both liquid and tissue. So in this study, tepotinib in treatment naive patients, the efficacy, you can see the tepotinib has a robust and long-lasting efficacy in treatment naive patients. Those enrolled via tissue biopsy, overall response rate in treatment naive patient is 58%. Median duration of response 26.4 months. Median PFS 15.9 months. Median overall survival almost 30 months. So 90% of patients experience tumor shrinkage with tepotinib, and tumors are consistently sensitive to this drug. Similarly, in previously treated patients, they also demonstrated robust and lasting efficacy. So overall response rate also it is promising, 49%. Duration of response 10 months. Median PFS so slightly less in comparison to treatment naive. It is 11.5 months. Median overall survival 20 months versus 29 in treatment naive patients. So tumors are consistently sensitive to this therapy even in subsequent line of therapy, and this is the efficacy in Asian subgroup, and you can see median PFS in treatment naive 16 months, and in subsequent line of therapy at least 12 months, and the overall survival 32 almost 33 months, whereas in ITT it is only 29 months. So this tepotinib have Asian patient it was better, though numerically it is slightly more, but statistically not significant. So it is 33 months almost, and in subsequent line therapy it is 24 months.
5 minutes, sir.
In brain metastasis subgroup, intracranial disease control at 88.4%, response rate 67%, 20.9 months intracranial PFS. So in brain metastasis, the disease control rate is very good. Another drug that is capmatinib, which based upon the geometry, phase 2 geometry trial, it was approved in 2020, and overall response rate in capmatinib is 44%, duration of response 9.7, and median PFS is 5.5 months. So if we compare both these drugs, then the intracranial response rate is almost 71% in tepotinib, 54% in capmatinib, and dosing schedule, it is once daily 450 milligram tepo, and capmatinib, it is 8 minutes twice daily. So slightly better dose schedule in tepotinib, median PFS in ASEAN overall, you can see in tepotinib 16 months, 16.5, and overall it is 12.5 months. So in second line also, there was the PFS almost 12 months. And this is the same comparison, though it is a cross-trial comparison, both tepotinib and capmatinib. Median PFS 22 versus 12, median was almost 30 versus 20 months, duration of response 46 versus 12. And this is the dosing schedule. Because tepotinib has longer half-life, so can be used as a single dose daily, 450 milligram. Capmatinib, shorter half-life, twice daily dosing, and 2 tablets, 225 milligram, 2 tablets. Whereas in capmatinib, you have to take 4 tablets. Dose reduction schedule is slightly better. Either 450 you can reduce to 225, a single dose. Whereas capmatinib dose reduction is slightly complex. You are almost 3-4 dose reduction schedule. Toxicity, edema is a class side effect of almost all the med TKIs, and followed by nausea, creatinine increase, AST, ALT, transaminase increase, fatigue, hypovolemia. So edema is the most common toxicity, and the mechanism, though it is not clear, but may involve inhibition of MET in vascular and lymphatic endothelial tissue, and it can be measured by prevention, limb elevation, exercise, compression garments, lymphatic measure, diuretics like pyroxamide, regular monitoring, or you can manage by dose reduction or interruption, permanent discontinuation. Dose reduction does not affect the efficacy of this tepotinib also. So, summarizing, it is tepotinib recommended as a preferred treatment by most of the guidelines. The GEM study is the landmark trial, and it is one of the largest trial of these patients, and first study to enroll patients with both tissue and liquid biopsy in first and subsequent line of therapy. In frontline setting, 90% of patients experience tumor shrinkage, and 16 months of PFS, almost 30 months of OS benefit. In brain metastasis, 25% brain penetration, 88% intracranial disease control, and almost 70% intracranial response rate, 21 months median OS in brain metastasis coverage, and the dose convenience is better, and safety-wise, only the edema is the class side effect, which can be controlled by preventive measures. Thank you very much for this.
Thank you, sir, for completing it well in time. Sir, anybody has used this drug, the actual safety profile and the adverse effects yet?
So I have not used yet.
I'm asking, it's an open question.
Yes.
Anybody can
share their.
Hi.
Saurabh, yes.
So we used
Yes,
actually for one patient, I think we used capmatinib.
Okay.
Capmatinib,
So
okay.
how the Saurabh, you have seen edema in those subgroup patients?
Yeah, that's what I was about.
You have seen
edema, any
toxicities? Toxicities?
I have used it. Prashant, I have used in 2 patients. Both of them had grade 2 edema.
Okay.
So edema is a common.
But then how does that affect? Does edema, is that big a concern where we need to interrupt or
because
modify dose?
One of
No,
my
no?
patient was in a trial, and the other patient was on a commercial year. So both patients had an edema.
Romila, this edema can be managed by prophylactic measures like limb inhibition, compression bandages, and we have always option of using diuretics also. So
That's
those
true.
can be managed, but as we use these drugs, so we'll be more acquainted with these drugs. And
I was just wanting to gather some information. Thank you very much. Now we proceed towards our next talk by Dr. Ashok Kara, all the way from Sheffield, UK. Heartiest welcome, sir. He'll be speaking, he'll be giving a surgical perspective to management of lung cancer in this era of neoadjuvant immunochemotherapy. So, Dr. Kara, all over to you now.
Hi there. Good afternoon, and thank you, everyone. Can you hear me okay?
Yeah, you're clearly audible. Yeah.
Great. I'm just trying to share my screen. Just give me a second. Sorry. Oh dear.
Anita, is the screen sharing allowed? I mean, like, is the access given?
The access is already there, ma'am.
Okay, all right.
Yeah, sorry. My Zoom
That's
is
absolutely fine.
playing up. Hopefully this will work now.
Yeah, it's visible now, sir.
Great. Right. Good afternoon from London and good evening, everyone in India. Thank you for the opportunity, to the organising committee and particularly Dr. Das for inviting me to share my perspectives on the management of lung cancer in the neoadjuvant immunochemotherapy era. We've already heard quite extensively today about some exciting topics, including summaries of the Pacific trial and the Checkmate 816 trial, along with ctDNA. I'm going to offer a UK surgical perspective. Practices are in North America and obviously in India as well. I have no disclosures. I'm a consultant thoracic surgeon working in Sheffield and also an honorary senior clinical lecturer at the University of Sheffield. So in terms of my outline, I wanted to go in a bit more detail about some of the key recent trials in non-small cell lung cancer involving neoadjuvant immunochemotherapy. And this is really a very, very exciting time for oncologists and surgeons trying to all work together to improve patient outcomes. I'll talk a little bit about how we've been trying to implement this changes to the pathway in Sheffield and share some selected case experiences before offering some final conclusions and future perspectives. So in terms of the key trials, I suppose there are three that come to mind, all published in the last 18 to 24 months in the New England Journal of Medicine. The Checkmate trial, which was published in April 2022, and that was looking at only neoadjuvant immunochemotherapy. And then in the last year, subsequently, the Keynote trial with pembrolizumab, and then the Aegean trial with durvalumab, which is the most recent. Notably, these trials had neoadjuvant and adjuvant immunotherapy. So as a surgeon in this context, to be switched on, need to think about, is there evidence to consider this prior to surgery for, remember, resectable non-small cell lung cancer? And there's always a debate in the surgical community about what is resectable. Some surgeons say it's not resectable, then you find a surgeon that says it is resectable, particularly in the context of N2 disease. And I think that's important to bear in mind. So the Checkmate trial, Checkmate 816, this was a multi-center randomized controlled trial. And in terms of its design, it's already been touched on earlier on today, but essentially this trial looked at patients that were in stage 1B, more than 4 centimeters, or with nodal disease, stage 3A. And interestingly, in this trial, they had sort of 3 cycles, so 9 weeks of treatment prior to radiological restaging and then surgery within 6 weeks. The key point is that the primary endpoint was pathological complete response or event-free survival with further secondary endpoints. Now, in the UK, earlier today, Dr. Das had hinted at it, we have to think about our standard of care in the NHS, and it's very protocol-driven, which is frustrating at times, but in a scenario like this, quite helpful in terms of who we should offer this treatment to. And this is from the UK NICE guidelines in 2023, and I just wanted to highlight very clearly that this patient subgroup is managed quite differently in the UK. So if there's multistent or bulky N2 disease, they may have chemoradiotherapy prior to surgery. But otherwise, it is not UK practice to give platinum doublet chemotherapy prior to surgery. And in the trial, of course, we're offering platinum doublet chemotherapy as standard of care versus adding immunochemotherapy. And so there's been a lot of controversy amongst UK surgeons about how to interpret these trials, because we're also not giving standard of care, which is going straight for an operation. So in terms of this primary outcome, well, there was 358 patients, as we can see, and we can see the event-free survival curves. The median event-free survival, there's a very significant difference between the two, 31.6 months versus 20.8 months of chemotherapy alone. Now, in that mind, you certainly sit up and you think as a surgeon, well, hang on, we can definitely do something here to help our patients with their event-free survival, which is important, and we need to engage in this. But when looking at overall survival, I suppose the data is early, but the curves have differentiated and it's not significant. And then we wanted to look at the specific subgroups. And I think this is important, which wasn't touched on earlier today. But in the stage 3A subgroup, the nodal disease group, we can see there is a significant difference between the immunochemotherapy versus the chemotherapy alone group. And so this is quite a controversial and challenging group to manage of patients in terms of surgery and multimodality treatment, along with chemoradiotherapy and now immunotherapy. But clearly there is a benefit here for these patients, which shouldn't be ignored. Equally, as a surgeon who wants to offer upfront surgery, for any tumors above 4 centimeters, the curves don't differ that much. So actually, in this case, should we be offering this routinely in this subgroup of patients? And the guidelines don't mention that, even from NICE, the National Institute for Clinical Excellence. And I think this is where the devil really gets into the detail, because we're saying that this is great, it's fantastic giving immunochemotherapy, but actually, if we look at the patients who went on to have surgery, even in the immunochemotherapy group, only 84.6%. So more than 15% of patients don't go on to have surgery and have definitive treatment in something that's operable. And I think that's really important. Obviously, in the chemotherapy group here in the stage 3A, it's 30% of patients, but that's not really standard of care, is it? So we can ignore that. But in the stage 1B, particularly, that's a resectable tumor that's 4 centimeters. We're denying surgery and standard of care to 15% of patients. And I think it's really important in the context of these trials in terms of counseling patients and explaining to them the survival advantage in the long term in terms of event-free survival, but also the fact they might be denied treatment. And this has been a huge area of controversy in the UK, going on to the fact that it's not standard of care to give chemotherapy up front. And then again, with the surgical approach, surgery is very safe now for lung cancer and early stage lung cancer. In the UK, it's less than a 1% mortality with enhanced recovery. Length of stay is 3 days. Perioperative care is improved. But we see that in the trial, 90% of patients had a thoracotomy. In fact, only one patient in Europe had a minimally invasive procedure, whether it be robotic or video-assisted thoracoscopic surgery. And again, that's really important in terms of patients and their recovery and getting over their surgery, and then considering further adjuvant treatment as well, which with other trials, with Empire 10 and with the Adura trial, with EGFR or osimertinib, these are all trials suggesting you can have benefits for patients with adjuvant treatment afterwards. So we've got to think, should we be offering this to all the patients despite this landmark clinical trial? And then I touch on length of hospital stay, 10 days median stay. My patients tend to go home within 3 days or 4 days, 5 days after a thoracotomy. So this is increasing the length of stay, and the trials don't talk about the recovery long term in terms of the patients. I think this is what, however, is most exciting for myself as a surgeon, is this idea of a pathological complete response following immunochemotherapy. So in the trial, up to 25%, in the R0 subgroup, actually this was up to 30% of patients have a complete pathological complete response to the treatment. And this is now in the trial being linked to event-free survival. So the patients with the pathological complete response have a better chance in terms of event-free survival. And this is very exciting. But then the question then comes to a surgeon is, well, if you've got a complete pathological response, should we be doing surgery for these patients? And when should we do them, if ever? Because they're cured, aren't they? At the moment, we can only do this by resecting the tumor. But the trial then, very interestingly, goes on to look at ctDNA clearance as well. And okay, only half the patients had complete ctDNA clearance after surgery, but that's still a significant number. And with these assays, when they improve, hopefully we'll be able to tell whether we need to even operate or not. And then again, they are linking this ctDNA clearance to event-free survival. So it's exciting because these biomarkers and ctDNA hopefully will guide us in terms of treatment in the future. So the biggest thing that happened in the UK after the publication of this trial took about a year, but in March 2023 last year, the guidelines were updated and it made it clear that you can offer nivolumab with chemotherapy in the neoadjuvant setting if it's resectable non-small cell lung cancer. The caveat here, which is very important, is that there's no clinical trial evidence directly comparing this to standard of care in the UK, which is just upfront surgery. And bearing in mind 15% of patients might not have surgery, this is a big mute point in terms of our clinical pathways. The two other trials we can touch on are Keynote 671, which was using pembrolizumab for early stage non-small cell lung cancer. The trial design was similar, but it also involved adjuvant along with neoadjuvant treatment, and it was an extra cycle. And again, the event-free survival, we can see the curves are significantly diverging. However, because of the design of the trial, we're unable to establish if it's neoadjuvant or adjuvant treatment that is affecting the overall outcomes. And again, similar to the Checkmate trial, there is a pathological complete response, although being less so. But again, we go back to this, in Keynote, when is no surgery performed? Well, in the pembrolizumab group, 71 patients, 17.9%. And in this trial, the surgical approach and details aren't mentioned in detail, not that I can see in the supplementary paper. So again, we are possibly denying patients surgery who are operable. We're not doing it minimally invasively and giving them the best outcome that we've now established as standard of care. The Aegean trial, which is again more recent, uses durvalumab in this case, very similar to the previous trial. And again, in this trial, we can see that event-free survival is better using durvalumab, and there is a pathological complete response. But again, worrying for me as a surgeon is, 77-80% of patients, more than 20% in the treatment arm, didn't go on to have the operation that they were going to have because it's operable disease. And I suppose the lead author for this in the trial, this is a little concerning, is quite positive. And it says, he says, there was concern that giving neoadjuvant immunotherapy might make it harder for some patients to get to surgery. But in fact, we were happy to see that almost as identical number of patients were able to get surgery in both arms. But he seems to be happy that 1 in 5 patients doesn't get surgery. Now, I'm not saying not to be excited by the pathological complete response in all these trials and also the improvement in event-free survival.
40 minutes.
So,
someone has unmuted. Please mute yourself.
So again, summarizing these 3 trials that are landmark trials in the neoadjuvant setting, is there evidence to consider immunochemotherapy prior to surgery? Well, yes, especially in the stage 3 patients. And as we all know, this is a very challenging group of patients for us to manage. And there's definitely evidence that this will help. We do have to be worried and have to counsel our patients that 15 to 20% of them may not have surgery for resectable disease, particularly the stage 1B patients without nodal disease. And anecdotally, speaking to lots of surgeons, and this was discussed last year at the UK Society for Cardiothoracic Surgery meeting, and again this year, a year on when we're all starting to treat these patients, the patients with nodal disease are more challenging to operate on. But most interestingly, if there is a pathological complete response, then what is the role for surgery in the future? And I think that not having an operation is a good thing, ultimately, for the patient. So moving on to the implementation in Sheffield and South Yorkshire. So there is a changing landscape to UK NHS practice from 2023. This photo highlights the Peak District in South Yorkshire, where our hospitals are based, and the landscape has completely changed. Currently in the UK, some things are constant. There are 31 UK thoracic surgery centres in the NHS offering treatment for about 50 to 60 million patients. Our practice is heavily driven by NICE protocols in terms of the funding and the cost of our treatments. All the patients with lung cancer are discussed in a multidisciplinary team meeting with a surgeon and oncologist in attendance. These are all the patients, even the straightforward early stage, less than 2 centimeter patients, all the advanced patients, they all are discussed. Dr. Das and I work in a region that has a population of 1.9 million patients. From our surgery point of view, we offer more than 300 anatomical lung resections a year. Our practice in our department is uniportal VATS, and 30 to 40% of the patients are anatomical segmentectomy. In the context of all this, we're now having screening being introduced by the government in the UK finally, despite trial evidence in the US from over 10 years ago and in Europe in the last 4 or 5 years. It's only taken until now to increase surgical activity, hopefully in the next 2 years, by 25%. And I suppose if we look at the stage distribution of diagnosis of lung cancer, more than almost half is at stage 4, but it's predicted that 60 to 75% will be diagnosed with operable disease. With these papers and the trial evidence, therefore, there'll be a huge impact of neoadjuvant immunochemotherapy and the number of patients we potentially need to provide this treatment to. I think there needs to be some work now to be done to figure out which patient groups should benefit from this more than others, particularly the 3A group. So how are we implementing this in our pathway? Well, we have our lung cancer NDT, and the key aspects having a surgeon that confirms the resectability of the tumor and have appropriate staging investigations. And certainly working with Dr. Das, we have decided the best thing to do. I'm not a surgeon here to sell anything to the patient, but they should meet a surgeon first, because in the trials, particularly in Checkmate, there's a good proportion, 10% of the 8 to 10% of the patients who didn't go on to have treatment were often turned down by a surgeon at a later date due to poor lung function or not being fit enough. So it's important that the fitness of the patient is assessed early prior to going down this line. And then in terms of the informed consent, I certainly make sure the patients are aware of the options, and it depends on the clinical staging, and the cases will highlight that shortly, and let them decide what they want to do. And then after that, obviously, they meet the oncologist, start their treatment cycle. We keep in contact to see how they're getting on in terms of planning a date for surgery and restaging of the CT, chest to pelvis only prior to surgery. We don't repeat a PET. The patients usually had already brain imaging as per our protocols, but we don't tend to repeat any other invasive staging because if there's no disease progression, we can continue to surgery. So how is immunotherapy changing surgical practice? Well, we're having to have much more informed discussions in our lung cancer tumor boards, longer discussions about patients, working them up more rigorously. We're spending a lot more time with our patients, counseling them and consenting them as to their options. There's a lot more collaboration with oncology colleagues. From a surgical point of view, the technique is changing. We aren't able to do as many VATS operations and a transition away from minimally invasive surgery, even in the robotic setting. Even trying to do this robotically is challenging, despite the improved visualization and dissection available. And I suppose our perioperative outcomes planning in our hospitals, increased length of stay, increasing complications after surgery, adverse events, these are all aspects we need to consider for our pathways, which have been streamlined. I just wanted to talk about a few cases that we've had in Sheffield and with Dr. Das. So this is the first case, a 64-year-old current smoker who'd had a previous stroke, hypertensive, hypercholesteremic, PS1, good lung function, and he had a 64 millimeter biopsy-proven left lower lobe squamous cell carcinoma. And despite what I've just been saying about stage 1B disease, I think the feeling of the NDT was that if he's a current smoker, we can optimize him by getting him to stop smoking and giving him his immunochemotherapy, and also trying to do this minimally invasively, because at 6 centimeters, it'd be challenging to do this without doing a thoracotomy. And actually, after his treatment, during which he had the current urinary tract infections and had an episode of neutropenia with GCSF, there was no sort of neutropenic sepsis. We saw that the tumor actually had shrunk slightly. Now, we're not doing this as induction, but I suppose there is an element of that in terms of our patient selection, whether it be unconscious biopsy. He was able to have a uniportal lower lobectomy. There was minimal tumor response. Low expression, less than 1%, was a squamous cell carcinoma. He did develop an empyema postoperatively, which is managed with an intercostal drain. But I think this case highlights that it does work. This patient didn't end up being denied treatment, but it could be one that would have been operable if there was any adverse events, and we have to consider that carefully. Another case here, interesting case, right upper lobe mass, targeted lung health check in a 66-year-old ex-smoker. This tumor encroaches the right main bronchus, and when we discussed this in our MDT and tumor board, the feeling was we should offer, as per Checkmate, neoadjuvant immunochemotherapy. And there's been a remarkable radiological response in this case, and I probably will be able to get away with not having to do an evenectomy now. And he's scheduled for right thoracotomy and upper lobectomy sleeve resection next week. So let's see what the outcome is. But this is another area where it helps the surgeon by taking on these patients, because you can do more lung sparing operations. A third case, and this is an area that was discussed recently at our society meeting, cases with the single station N2 disease. This lady, 64, current smoker, hemoptysis, biopsy-proven lung cancer in the upper lobe with single N2 node in the AP window. Should be able to have a straightforward left VATS upper lobectomy in January. Counseled the patient, gave her options, explained the trial. Hopefully this N2 node won't help the difficulty of my dissection of the hilum. And she's now undergoing her third cycle, and then we'll proceed to surgery. So this is another patient we've selected based on the trial evidence to continue. I bring this case up as well. This is not a neoadjuvant case, but this is in view of the Pacific trial. I know I was meant to talk only about neoadjuvant cases, but I think this is interesting. This is a smoker with inoperable non-small cell lung cancer who's 58, absolutely devastated in August 2023. As per Pacific, non-resectable in this case, so went on to have chemoradiotherapy. This is based on this trial evidence, which was outlined earlier today, showing the survival benefit and event-free survival of undergoing this treatment regimen in the non-resectable scenario. And then when this case is rediscussed from August and December, when the patient's due to start nivolumab, we see that there's a marked response to the tumor. And in fact, on a PET scan and a staging PET, we see that this is probably operable now. And the decision was made with conventional chemoradiotherapy to then proceed to a salvage operation. And the patient underwent a left thoracotomy, upper lobectomy, and sleeve arterioplasty in February. We used this cryoprobe to help with pain control, and the patient's discharged within 4 days. Final pathology, YPT0, no viable tumor found. And I highlight this case because we keep talking about immunotherapy and complete pathological response, but we all need to remember, surgeons need to remember, that oncologists can still deliver chemoradiotherapy that is successful with no viable tumor remaining. Sort of final point about this is the role of ctDNA in detecting residual disease in the future. This trial study came out several years ago from the US, a group that I've done some research with. And this clearly shows that at diagnosis, circulating tumor DNA is detectable, but following chemoradiotherapy in the different phases, even though there's a tumor visible on a scan, there's no ctDNA detectable, and this patient is cured, similar to the case that we've just had. So what are the conclusions and future perspectives? Well, the neoadjuvant immunochemotherapy is definitely changing the landscape of surgical practice and what we do as surgeons and what we can offer. It makes our job more challenging, but we need to work with the oncologists collaboratively. We need to counsel and consent our patients very carefully. I strongly advocate that a surgeon meets this patient first, gives them their options, assesses their fitness for surgery and whether to go through all of this. Because if they're a borderline case, we have to then consider whether we should put them through the risks of neoadjuvant immunochemotherapy when they'll be denied their surgical treatment, where they could have something adjuvant. And surgeons must adapt their practice and techniques as well, because we'll not be able to do as many minimally invasive operations. And again, think about that and the impact on our services and units. In the future, I suppose with ctDNA and biomarkers, should we be operating on patients with a pathological complete response? I think this is going to be a really exciting area in the next 5 years in terms of what we do. And will we be guided by these novel biomarkers in terms of timing of surgery? So in conclusion, I hope I've been able to give you a bit of a perspective on this neoadjuvant immunochemotherapy era from a surgical point of view. Thank you very much.
Thank you. It was a beautiful session, and like it was such a wonderful talk. You touched almost very important aspects. A little different scenario in our place where we just get stage 4, matlab bulk of stage 4 diseases, very few operable cases. If I'm not wrong, anybody can correct me. So
I have a question. So Dr. Ashok, see Dr. Vishwas. So nice
Hi.
to hear you.
No, thank you for the opportunity.
Yeah. So actually Tathagat connected you, and that was great. So we'll involve you more in the virtual and if possible physical also. So
No,
as
absolutely.
as Romila said, so we see, because we don't have a screening program, so definitely our bulk of patients are stage 4 patients, and our surgeons probably so 1 out of 10 or maybe 2 out of 10 actually undergoes the surgeon's knife. So we have debates on this immunochemotherapy. So many of our surgeon feels that so otherwise resectable patients might turn out to have a progressive disease and not fit for surgery. So what is your take on that? And secondly, so otherwise resectable, so how do you choose your patients personal for a neoadjuvant approach?
Sure. I think those questions are similar in some sense. I mean, I appreciate we're working in different areas in terms of screening and diagnosis of patients. It's only coming now in the UK. But certainly, I think we have to physically assess the patient. It's really important that, that when they get referred via the NDT and a respiratory physician, which is what happens in the UK, they must meet the surgeon first to avoid the situation where they're not fit. Because you can't just look at their exercise, the cardiopulmonary exercise test and the lung function. You really need to assess their fitness, whether they're going to look after themselves or not, whether they're fully screened in terms of other reasons why they may not tolerate immunotherapy. So I think that's one of the key aspects, because some of the trials you can see that I don't think it's 15% of patients that really don't make it. I think it's less than that. I think that they're not worked up properly in the first place. It's alluded to in Checkmate, and that's why it's really important to do that. In terms of my own personal selection, I alluded to it. I gave you a set of cases. We did give it to a stage 1B 6-centimeter tumor. I think I'm leaning on what can make a little bit my job easier. So, if it's bulky N2 disease, okay, we're not talking in the induction setting. It has to be resectable. You find a surgeon, they'll say it's resectable through a thoracotomy. So it's a question of, this is clearly giving, 1/3 of patients who have an R0 resection complete pathological response. We have to give it. We don't know the science yet in terms of what absolutely to do.
So you are right. So basically, so we are not sure. So how this will go in the long run. So maybe at 5 years, because this is not like a breast cancer or a stomach cancer where pathological CR, even in those diseases, is not converting into a great survival. So overall, getting a major pathological response and even a complete pathological response, will this disease turn out to be a long-term survivor? So probably future will say that. So at this moment, there are exciting things about atezolizumab as an adjuvant therapy even.
No, I've seen that with Empire, exactly. And I think that's the group we shouldn't miss out on, is the adjuvant group. If they're resectable and we do an operation, what can we do to stop it coming back? That's always what I think in terms of an operation. Why is the recurrence rate what it is? I think the key point, and it's not coming out yet, probably because of the ctDNA companies, is they're not doing these assays that they're doing are, they're not tumor informed, they're tumor agnostic. There are expensive assays that take weeks at the moment that do detect, as I alluded to, minimal residual disease. And these are the patients I think will end up doing further treatment on only when they actually have detectable ctDNA.
Dr. Tathagat, you want to ask something?
Yeah, Ghanshyam, just one thing. Obviously, Ashok, thank you very much. Lovely talk. So Ashok has been to Orissa before. Okay, so his parents obviously immigrated to UK sometime back. The only thing I want to add, I mean, NICE actually advises for stage 3 multimodality treatment. So have had about handful of patients, probably between 10 to 20, who have triple modality. So initially chemo RT, then followed by surgery. And I would say about 70-75% of those patients were pathologically, basically complete responders when post-operative pathology was seen. I think the biggest challenge for us is the amount of work which we are getting in the NHS at the moment. This all is increasing my workload now, giving them neoadjuvant and adjuvant. So we are preferring actually neoadjuvant treatment because you get away with 3 cycles. But if you have to give atezo, then you are giving them for a year. So makes life much more difficult, clinic attendance wise, clinic capacity wise. But I think my personal feeling is it's going to stay. You have to be very, very careful about choosing patients because you might actually deny patients who are resectable upfront by wrong selection. So you have to be very, very, very careful about which patients you are selecting. So our the nice guidance actually for adjuvant atezo, we don't give it to I think 2A, we give it to 2B. So we are slightly more selective, where we are pretty sure that this group of patients are going to benefit from it. That's all I would say. Thank you.
Yes,
Thank
Saurabh,
you,
you want to say something? Saurabh, you have any questions?
No, I think what has been highlighted appropriately, this is a paradigm shift actually. I mean, neoadjuvant approaches and immunotherapy, PATH-CR, we do not know exactly how the PATH-CR is going to translate in an overall survival in the long term. But definitely this is a really paradigm shift, and we should offer this to our patients rather than the traditionally going for CTRT or so basically offer neoadjuvant approaches should be discussed with the patient very much.
Dr. Bharat Bhosle, you want to say something? Bharat?
Yes, thank you. An excellent talk. See, overall in all tumors, we are now bringing immunotherapy from stage 4 to adjuvant setting and now new adjuvant setting. In lung cancer, pathological CR, and we are going beyond pathological CR, no another marker as a major pathological response, where no less than 10% of the tumor remains. And we do know this all is going on to get more patients, the survival benefit. But beyond that, de-escalation also we are looking at somewhere, no? Like if you see 816, we have given only new adjuvant, and the other two trials are new adjuvant as well as adjuvant. So somewhere in the future, we are looking at give few cycles of new adjuvant, see those patients responding, look at the ctDNA, and we all know now we don't know what is going to happen in terms of the survival, but definitely in the future we are going to use all this information to de-escalate not only the advantage in terms of the survival, but the financial toxicity is also going to be a challenge for the people staying in these continents. As we know, as you mentioned, there are 25% increase in the surgical resection in UK, but we are struggling here to get those patients for resection.
Yeah.
So what Dr. Pillai said is very important. So when we get a patient for resection, then it is best to have all the modalities, at least for those patients who can have access to those.
Yeah.
And I am going to debate with Ghanshyam Dada on the same thing about that asumertinib in the resected patients. So thank you so much for enlightening us with the work going on. And we do see a role of immunotherapy in neoadjuvant as well as adjuvant setting. But our part of world has different challenges to get access to.
I appreciate
That's
that.
true. Yeah. All
Thank
right.
you.
Thank you. Thank you so much. And we now quickly proceed towards next talk by Dr. Saurav Mishra. He would enlighten us about the right choice of vessel access device, vascular access device in oncology. Dr. Saurav, over to you.
Yeah, so I'll share my screen now.
Yeah.
So this is visible, right?
Yeah, it is.
So good evening and thank you again for inviting me for this talk. So PICC lines are a very, very crucial thing for most of the cancer patients. Although we use them selectively, what I'm going to emphasize here is that we should use it more often. We need these things to reach to the patients, the benefits of PICC line. And that is what I'm going to discuss, the global guidelines, Indian practices, and resolving the barriers. So basically, it seems as if the venous access is minor, but just know that this is the most important thing. You just imagine how much headache we have when we don't find a venous access We put the lines on the patient's legs, and it is such a difficult thing to do. It's difficult, cumbersome, and painful for the patient. So definitely venous access, although seems minor, is the most important element for successful chemotherapy or any form of injectable therapy. So if you do not have a proper venous access, then all these complications will be there. Because of the irritant and vesicant properties, most of these patients, improper venous access, we see they have some form of a phlebitis, thrombophlebitis. And most of these patients, that is 1 in 5 patients receiving the irritant vesicle chemotherapy, experience extravasation. So this is actually grade 1, 2, 3. So extravasation is also there because of a improper venous access. So what does the guidelines suggest? So simple, if it is only up to 5 days, then you can use a peripheral cannula. If it is for a critical patient, those who are in the ICUs, you need midline central venous access devices, subclavian or jugular. However, for cancer patients who are receiving these chemotherapy drugs, preferred would be PICC line or port or a tunneled catheters. So this is what is recommended for cancer patients. So in Indian practice, what are the challenges? The types of chemotherapies, what we are using in our routine practice, expected duration of treatment, how long the line has to be there, what is the dose intensity, vascular integrity of the patient, appropriate patient. This is the most important. You are going to use a PICC line. If you don't teach them how to keep the PICC line in situ for long period of time, just you are wasting your time and wasting the money, and also you are giving pain to the patient. So it is essential that not only you should explain to the patient why he needs a PICC line, you should also explain to the patient that even if there is a PICC line, how to take care of it. Otherwise, it's just meaningless. So the vesicant and irritant drugs, you know, anthracyclines, vincal alkaloids, and alkylating agents. These are the vesicants, and the irritants are all these drugs. So for all the vesicant irritants, so suppose someone we are giving breast cancer AC regimen, we should be using this venous access, central venous access devices for all the vesicant irritant drugs to avoid the vascular complications, preventing extravasation and thrombophlebitis, and also avoiding frequent pricks because you are giving it periodically. You need blood samples. If you have a venous access device, you can use them for phlebotomy also, for rapid blood transfusion also. Just take an example here, anecdote. So if you go for a non-small cell lung cancer patient without any driver mutation and who has no overexpression of PD-1, you would need around 72 pricks in a year. Average blood sampling treatment, 25 needle pricks. Then, assuming one only episode of febrile neutropenia, 3 lines of chemotherapy, you will need around 72 pricks in a year, which is just imagine if you are to undergo 72 pricks. So these are the guidelines basically from the ASCO, from the NHS, from other societies. It is intended for patients requiring up to 12 months of IV therapy. Dwelling time ranges from 7 days to 34 months, cited for treatment lasting a few days to many years, and PICC line can stay in your arm for as long as 12 months. So these are all the recommendations. Also, you can see here some studies, 269 PICC patients, 98% solid tumors, median 184 days. Very well, that is 6 months, pretty well, median, most of the lines could be used. What are the barriers? So we at our center, we have, although the trained nurses who can put the PICC line, we are usually getting the PICC lines done by the radiologist under ultrasound or fluoroscopic guidance. But what here shows that even if you don't have that facility, the nurse-led PICC insertion, it is cost effective. The radiologist group had a statistically significant increased cost over the nurse group. So nurse bedside can put the PICC line. If you have an radiologist, it is also definitely, although the outcomes are good, but costly it is. So nurse-led PICC team, cost reduced by 60% and success rate of 90%. So these are also the guidelines. All these guidelines suggest that although ultrasound guidance for placement of long-term vascular devices, that is by the radiologist, significantly reduce early mechanical complications. But if you don't have a ultrasound guidance, if you train your team very well, they can do very good results and comparable results. reduces all complications. It is cost effective. So basically what we need that there should be peak placer centers. So you should train them all across the country. There are a couple of centers who do training courses. It is emphasized that the nursing team should go and train there. So coming to the types of devices, open-ended PICs, single, dual, triple lumen, closed-ended valve PIC. So we use predominantly the Groshong PIC. You know, it's a peripheral inserted catheter and silicon blue tube catheter with rounded radio distal tip. And there are 3 pressure positions here. They do not require heparin or catheter for catheter flushing or locking, and they come in 2 sizes. So there are 3 ways here. One is the negative pressure valve. So when you suck in blood, so this valve opens, blood gets in, and then there is a positive pressure valve. When you push chemotherapies or drugs into this, then this opens, and when you don't do anything in the neutral pressure, the valve remains closed, thereby reducing the risk of air embolism, blood reflux, and clotting. So basically, what is the benefit? Longer dwell time, reduced venipuncture, lesser vascular complications, all these are there. Dressing requirement, avoiding complications. So although there is a training to be done for most of the staff, what we do is that for the attendants, we do training regularly so that they can go and do the weekly PICC line dressing at their home. So this is done at our center also. Other thing here is that this is a stat lock which we are seeing here. So if you put a suture, it is usually a painful procedure. You have to put a suture, you have to insert a prick, but the stat lock, it's just like a sticker. It can very well be placed. And this sutures based compared to suture based stabilization, there are lesser complications, lesser failure rates, that is premature removal rates, and easily it can be removed. You can change a stat lock also many times. So this is also an easier way. Only complication what we have seen is that when the stat lock is placed there, usually there are certain local site dermatitis and all. Pre-filled saline flush is also useful. Usually we use a 10 ml Dispoven. We do not use a 5 ml or 2 ml that causes risk of rupture to the PICC line. We usually use the 10 ml Dispovans to use it. So basically CVADs are recommended for all vesicant and irritant infusers. Chemo agents having pH less than 5, more than 9, infusers with osmolarity more than 600 milliosmoles, total parenteral nutrition, blood and blood products. Need to check and document venous status. For every patient will be starting chemotherapy. PICC should be considered for both continuous and intermittent chemotherapy when the same is either irritant or vesicle. And it has been successfully used for short, intermediate, long, median 6 months easily. USG guided PICC line preferred. If not, you have a very well dedicated PICC team. No, the results are equally good, and you should be able to train them thoroughly. You should keep on training the team so that you have a better outcome. So our twist with PICC line. So in 2016, we were training PICC line program for almost more than 100 nurses through video. Live telecast was done from the operation theater, and where PICC line training was being done on the patient. So many nurses got exposed to that. This was our publication. So around catheter insertion success rate was 96%, maintenance success rate 73%, median catheter life 142 days. These are mostly in the pediatric setting. That's all. Thank you once again for the opportunity, and over to you, Romila. Thanks once again.
Thank you, Dr. Saurav. It was good. But then the thing is that just because that part is exposed, and then many subset of patients that we get in our particular, area of work, they don't, like the sterility, the hygiene is a big issue. And of course, the daily bathing and other, daily chorus gets.
So that's what, so importance is the training. You have to tell them.
Yeah.
That thing has to be emphasized from day one. You have to give them what kits are to be given to them, and they should be properly trained. Here, what we do is that we ask them to show and demonstrate that how they are going to do the dressing in front of us, and then they can go and do it at home. But of course, a lot of people, this is a challenge, definitely.
Yeah. We get many infections.
I have a different view over here.
Yeah.
I completely agree with Dr. Saurabh Mishra. See, we treat acute leukemias and we use very commonly PICC. And we just have to be more intensive for solid tumor patients. If you
Yes.
count on the patients, they will keep the lines. I have patients who have been keeping their lines in very good condition for 1 year. In case of febrile neutropenia, it is very easy to take out the PICC.
That's true.
And you have deadly complications with the port as well. Sometimes
Yeah.
the thrombosis happens.
So,
I have a
that is
patient.
exactly what I was telling Bharat Bhai. So basically what I said was that although
I
we are
agree with you. Yes, yes.
right, we need to be more pragmatic about using them in more solid malignancies.
Yeah.
And right, that's what you are also saying, right? We should be using more in the solid.
More of
malignancies.
PIC line.
Thanks.
In solids, right?
So Romila, get with the quiz now. Then
yeah, sure.
because
Next session, like before there's a slight change. We were supposed to go ahead with debate, but then we go ahead with the quiz as of now. Can we have Dr. Sachin Sekhar Biswal to take the second quiz of the day?
Am I audible?
Yeah, you are, sir.
Okay, I'm sharing my screen.
Yeah.
Sir, with your permission, can we share the screen from our end, sir, so that we can have the timer for each quiz as well?
Sure, sure.
Yeah.
So very good afternoon, everyone. Let's go on with the quiz. We have 5 questions. And after asking each question, we will have 40 seconds of time. Whoever answers first in the chat box will be considered the winner. So this is the first question. As we are all aware that EGFR TKI, their very important side effect is interstitial lung disease. So this is about the side effect, which is ILD. Which among the following is false? The incidence of EGFR TKI induced ILD is higher among Asians. The reintroduction of EGFR TKI after symptomatic improvement has no OS benefit. TKI can be reintroduced after recovery in more than 80% patients. And the overall occurrence of ILD is higher with osimertinib than with gefitinib.
Shall I move to next slide, sir?
What's the answer? So you need to reveal the correct
Can
answer.
we go to the answer now?
Yeah, yes, please.
Okay. Let's go to the next slide. The answer is B. This is one original study published in 2024 January. The only thing that has no OS advantage if the TKI is discontinued. Even most of the patients after recovery can be rechallenged with the same EGFR TKI, and with rechallenge also there is significant OS advantage. Let's move to the next slide. The previous one, please. The incidence of EGFR TKI induced ILD is higher among East Asians, and it is 4.5% for gefitinib, especially in Japanese patients. The rate of reintroduction was 81.9% after improvement of ILD, and the rate for ILD for osimertinib is 12%, which is compared to 4.5% with gefitinib is higher. So let's go to the next question. This is one easy one. Which of the following is not an uncommon EGFR mutation? So I am seeing a very enthusiastic response from everyone. Can we go to the answer now?
Yeah.
Okay. As we all know, the answer is D, which is very well-known sensitizing EGFR mutation. And 861Q and 719X, these are the most common uncommon mutations. Okay. Among most prevalent uncommon mutations, so as to say, usually afatinib or osimertinib are recommended in the treatment of these mutations, as well as chemotherapy can be. So let's move to the next question. Okay, this is about exon 20 insertion mutation. We have to find the odd man out. Okay, there are a lot of correct answers. I'm not seeing any wrong answers till now. Can we move to the answer?
Answer, yeah.
The answer is D, anilotinib. Anilotinib is an FGFR inhibitor and also multi-tyrosine kinase inhibitor like VEGFR and PDGFR. It has been approved in some phase 3 trials in lung cancer after second line, after 2 lines of therapy. And it has been, phase 2 studies has been going on in soft tissue sarcomas. So let's move to the next question. So this is also an easy question, which is not an indication of invasive mediastinal staging. So very good response. I am not seeing any wrong answers till now. So this is an easy question, I guess. A central tumor with normal mediastinum is not an indication for invasive mediastinal staging. The answer is B. If the central tumor has enlarged N1 nodes, then only we go for invasive mediastinal staging. Let's go to the next question. This is also an easy one, which is not an indication of post-operative radiation therapy in lung cancer. So can we go to the answer? The answer is D. N1 disease is not a routine indication of postoperative radiation therapy. Okay. So I thank you everyone for the patient.
Thank you. As we gather the result of the quiz, we now move towards the final session of the day, the third debate of the day, and with interesting speakers who will speak against and for adjuvant osimertinib in post-op EGFR positive non-small cell lung cancer. Dr. Bharat Bhosle would be speaking for it, and Dr. Ghanshyam Biswas will go against. And we'll have a final expert opinion from Dr. Vibhas Biswas from Kolkata. So can we please take it up? Dr. Vibhas, you are around?
Yes, I'm here.
Yeah, sure. So we start with Dr. Bharat Bhosle. Yeah.
My slides are visible.
Yes, they are.
Yeah. First of all, thank you so much for giving me this opportunity. And now my role has been changed from the expert, giving the expert comments to advocacy of the osimertinib in early stage EGFR positive mutant NSCLC. Okay, so there is no need to debate. We have a level 1 evidence. I am not able to move the slides. Okay, yeah. Yeah. So the adjuvant osimertinib, the answer is yes. Why? We have a level 1 evidence. There is a phase 3 randomized trial. So we have discussed now what is the problem. Western countries, they are up to 30% of the patients are coming for resection. Majority of them are stage 2, stage 3. And I will not go into detail because we struggle to get up to 10% of the patient for resection. So as I mentioned, our job is to do whatever best possible evidence available with your own experience and precision. And we are living in the era of now precision medicine as well as the evidence-based medicine. So surgery is the mainstay, the primary backbone for these early stage NSCLC, and adjuvant cisplatin-based therapy, that is doublet. Since last 2 decades, we have 5-6 trials and meta-analysis which has shown that there is a 10 to 20% reduction in the risk in terms of the hazard ratio. And we have been practicing platinum doublets, Pacli-Cabo, Pacli-Cis, or Dosi, or GEM, or Vinorelbine. So since so many years, and the only challenge is to get the fit patient for the surgery with the fitness, because you have majority of these patients beyond 60s with the compromised lung functions, Yes, at the same time, the age is also younger patients are developing this malignancy. But again, our major challenge, as you mentioned, Dr. Tiwari, is most of these are stage 4 or non-operable stage 3. So whatever limited data, now we are becoming wiser and we are having the data from our Apex Institute from Northeast, be it North or Mumbai or South. In Asian, the EGFR percentage is up to 40%. And if you look at the stage wise, it is more or less similar. So to put up my point, I would just like to show these figures, and everybody is well aware about this. This is the ADURA trial where the primary updated analysis of stage 2 and stage 3A. You look at the 48 months progression-free survival with the hazard ratio. I am not going to quote the figures. No, everybody can see the figures. And this is for early stage from stage 2 and stage 3A. The hazard ratio is 0.23, statistically significant. Then this is the primary updated analysis in the overall population. So the previous graph was stage 3 and stage 2, and this is for all the patients. Here also, if you can look at the 48 months figures, more or less, statistically significant as well, with the hazard ratio of 0.27. Then if you look at the stage wise, as most of these patients fall into stage 2 and 3, but in all the stages, adding osimertinib, the 4-year DFS advantage is equally good. In stage 3A, the hazard ratio looks good, 0.2, and stage 1B is 0.41. Across subgroups, osimertinib is helping. If you look at the overall population with with adjuvant, without adjuvant chemotherapy, definitely there is an advantage of adding osimertinib. There have been attempts to improvise with the first generation TKIs, and we know that we have failed, but this is the first attempt where adding adjuvant TKI has significantly shown the DFS benefit. Overall survival, yes, Dr. Ghanshyam is going to debate about it, but at 60 months, you have figures of 73% versus 85%. Somebody is getting 7 plus 5, this is almost 10-12% of the benefit, delta of 12%, 5 years OS advantage is there. So look at the hazard ratio, 0.49 with the p-value of 0.004. So I am not going to say anything beyond that. Local recurrences happens, and that can be tackled with newer therapies, the dedicated targeted radiation. The major challenge is the distant
1 minute.
And CNS recurrence is our main challenge in any of the mutation positive lung cancer. Look at the CNS DFS. Definitely adding osimertinib prevents those CNS recurrences, and compliance is a big issue in our patient. This is placebo versus osimertinib. You look at local recurrences versus systemic recurrences. Definitely one should consider osimertinib here. And you look at the subsequent treatments, I see people have received even after placebo the subsequent treatments. And NCCN guideline latest shows that osimertinib 80 milligram daily has been incorporated, whatever level of evidence they want to say, but it is there in the NCCN guideline. So these are the yes for adjuvant TKI. It has shown a DFS benefit, it has shown OS benefit, it has shown CNS DFS benefit with adding osimertinib. And our major challenge for these patients, if you put up these patients for observation, majority of them fail distantly, and
30 seconds.
Patients fail distantly. Majority of these patients do not come for no follow-ups, and they lose the important treatment if we don't add osimertinib in the adjuvant setting. Thank you so much.
Thank you. Now, against Dr. Ghanshyam Biswas.
So Bharat has to stop sharing, no? So then...
1 second.
Okay, fine.
Have I stopped sharing?
Yeah.
Sorry, Dada. You give me 2 seconds more.
So Romila will give me 1 minute extra then. So my slides are visible, right?
Yeah.
So I'll be speaking against the motion. So this is introduction, so nothing much to deal. So in 2020, we had a PFS for EGFR positive NSCLC from stage 1B to 3A. But these were enrolled from 2015. The AGCCs changed and many of these stage 1B actually moved into stage 2. So the whole story is on the left-hand side, the NEGM article of 2020 and subsequent update was presented in ISMO 2022 about the DFS benefit of 3 years of osimertinib, the ADAURA trial. On the right-hand side, the updated last year, June 2023, which was presented in ASCO 2023, showing the benefit in regards to an OS. So one was a primary endpoint and the other was a secondary endpoint. This is the natural history of lung cancer who has undergone surgery. The upper one, post-surgery, no treatment. And see the curves when this patient post-surgery received adjuvant chemotherapy. And third is somebody post-surgery, then adjuvant TKI, the first generation. So those were the old trials, what Bharat showed. So there are two sides of every story. So on my left-hand side is Bharat Bhosle BB. On my right side is Bivas Biswas BB. In between is GB, that is Ghanshyam Biswas.
What I observed.
So is this an issue even relevant? So when Romila was talking about advanced lung cancer, so where a resectable lung cancer, we are not in a country like Dr. Tathagat and Dr. Ashok. So numerical terms of patient populations, at least after the ADAURA, I haven't had a single patient on a resectable lung cancer that has come to an EGFR. One patient who was supposed underwent surgery in Mumbai, post-surgery EGFR positive, when I evaluated here before the treatment, it turned out to be a metastasis on a PET scan, which was not there on a CT scan. So the ideal trial design would have been surgery followed by chemotherapy. If the patient GC is fine, then we know that a chemotherapy has shown benefit, and then that would have been randomized into TKI versus placebo. So what this trial did, so irrespective of chemotherapy, these patients were offered osimertinib. So how did somebody come with a proposal of 3 years, so magical number of 3 years of adjuvant TKI? So why not 1, why not 2, why 3? So this has come from previous trials of those first-line EGFR showing a benefit of BFS of 12 months, then 21 months, and then they thought, so let us take another 1 year extra. So the faulty trial study design, wrong staging of patients, because today, if any patient undergoes a surgery, so we'll do a PET scan. So why was MRI and PET CT not done for all patients? So PET CT and MRI are mandatory for today. Dr. Ashok is there, the surgeon is there here. So he will agree that it could have definitely impacted the results, because if you see, so it means there are many patients of micrometastasis which actually got benefit of osimertinib. So baseline staging adequate, increased rates of relapse in the standard of care arm. Chemotherapy was not meant because 40% did not receive chemotherapy. Rates of CNS metastasis in patients who underwent MRI had baseline, so maybe asymptomatic patients were not picked up. So this is Amol Akhade, so our great friend from Mumbai. Could we have improved on ADAURA, refining global research practices to reduce cancer care disparities? With Amol was Howard and Vishal Goyali, and this was tweeted like anything. So this was published in JCO Global Oncology in 2023. So now there is a perception versus reality. So Romila will think there are 3, while Bharat can think 4, even Vivas can think there are beyond 4. So the faulty endpoints, how come OS is a secondary endpoint? So we are talking about curative intent. So where we have put OS into a secondary, because we know that already first generation EGFR TKI had shown a DFS benefit.
2 minutes.
So DFS as a suboptimal endpoint. At that time, we argued that DFS was a suboptimal and endpoint because OS represents the decisive endpoint. And nevertheless, the US FDA considered DFS an acceptable, and they forego that probably OS can be a secondary endpoint. So DFS again as a secondary endpoint. By 2020, we knew that osimertinib has become a new standard of care for a metastatic setting. So accordingly, the most relevant contributory questions from ADAURA became where proactive administration of adjuvant osimertinib. So we did not see that. So then ADAURA was amended in April 2022 to permit before that, there was no crossover for those patients in the placebo arm to osimertinib. So OS benefit, so let me finish. So OS benefit demonstrated with caveats. So updated results from ADURA highlight a significant improvement in OS, as Bharat showed, but only 79 out of 205, means less than 40% patient actually received osimertinib on progression. So the inferior post-protocol therapy did not raise regulatory flags and should not be presumed to undermine the observed OS benefit. So the unbinding issue in ADURA trial. So ADURA phase 3 was a double-blinded study design. So would you choose money or luck or a lady love? So is ADURA adorable or not so adorable? So which one somebody is going to choose? So how will you manage someone who has progressed on osimertinib? While on osimertinib, while less than 6 months of stopping osimertinib, or 6 to 12 months of stopping osimertinib, and somebody who has stopped progress after more than 12 months. Now comes the tolerability and toxicity. So tolerability of the drug and toxicity of the cost. If you see the MRP of this drug in India is 1.51 lakhs per 10 tablets. So if the patient purchase 3 strips, which is 4.5 lakhs per month into 36 months. If you get the PAP program from AstraZeneca, so 1 strip plus 2 strips free. So still you can see a mammoth cost. And if the patient directly purchases from a company, so it becomes 1.2 lakhs per 30 tablets, including the PAP. Now coming to toxicity. So osimertinib associated diarrhea with 46%, and 2% of patients will have a grade 3 or higher diarrhea for 3 years. Just think somebody is a professional going to the office, so he has to go and hook up few frequent times. Paranoia in a 25% of the patient, and stomatitis in 20% of the patients. Some adverse events which were not mentioned, interstitial lung disease is such a high in lung cancer. So osimertinib reported in 3% of grade 1, grade 2, and just don't forget the QTc prolongation, which can cause sudden cardiac arrest. So to summarize, faulty study design, that is wrong staging of no MRI, of the scanning of the brain or PET CT, faulty endpoints, so OS was a secondary endpoint, and 40% did not receive adjuvant chemotherapy. DFS results in stage 1 were poor. OS results stage was not a good stage for stage 1 and 2. Some adverse events cannot be ignored. Subsequent treatment should have been patient progressing on the placebo arm should have gone into an osimertinib. So can you do better, maximize alignment among different stakeholders? So sponsor companies, healthcare professional, patient shall make common goals when considering clinical trials, but we should acknowledge that the goals of these stakeholders are not entirely resonant. Although everyone benefits from a positive clinical trial. So the sponsor company's primary mission is to conduct a better trial, regulatory requirements, and marketing. In the hindsight, we should not forget the patient's benefit who has consented for this research. So final take, ADURA is only adorable to select patients only. Hence, I raised my case against the motion. And we are friends, and we remain as friends after this debate with Bharat. Remember, my friend Bharat Bhosle is a charmer, a great singer. So don't get mesmerized by his talk. So to end, I had a thought, and then I had another thought. They bounced off each other. Now I can't find either of them. Thank you so much.
Thank you so much, Dada, for wonderful talk, first of all. But I can't accept your no. And I will take few points to rebuttal. So let him know. So I am only going to get more time because I spoke first. He spoke about endpoints. The trial was designed by the experts. Yes, every trial is going to have policies, but good number of patients, and this is EGFR positivity is seen in up to 40% of the patient, and this is the only trial which showed adding adjuvant TKI has shown whatever primary endpoint chosen has shown benefit, and the secondary endpoint. Now in oncology, we have used drugs for the sake of 2 weeks of benefit. Now here you see, you ask next, what is next after the failure? Now look at the graph, Dada. Look at the graph. No, at 60, 90%. 10% patients are failing. 90% are not failing. So for those patients, you mentioned that patients are not coming for resection. The same is true in Mumbai. Hardly patient come for resection. Then it is our responsibility. Whatever knowledge we carry, we must discuss with the patient. And you only mentioned for select patient. But for those select patient, you also agree, yes, it is adorable. So I am just advocating with those patients, not for all patients. I agree with you. Then you mentioned about toxicity, which is a financial toxicity. Dada, I called you long back. I will not mention because it's an open forum. How is your experience with that osimertinib? You said it works, and I have a patient who is on 5 years on that. That toxicity can be managed. You and me know how we can get those drugs for these patients. So I will not talk about the pounds or dollars. It is manageable in Indian context, and you can get it at affordable, accessible cost. Then diarrhea. I personally don't see that much of diarrhea, because now I am using abemaciclib as well for the adjuvant breast cancer patient, where if you compare with the other drugs, it is much better as compared to the other TKI. ILD QT, yes, I do agree. It is a drug which is the most common drug causing ILD among the TKIs used for lung cancer. But your patients are coming for regular follow-up with imaging, which is a low-dose CT. Yes, at the earliest sign of this ILD, you can stop the drug. And QT, yes, all the medical oncologists, we are looking at the QT prolongation, and it can be stopped well in time if you really look at the ECGs. And I do agree with you, as you mentioned in your slide only, that select patients, yes, it is adorable and it must be used. So you are agreed to that point, huh, Dada? Thank you so much. And I think that the debate is over. We both.
No. The expert opinion has to come. Now he's in a dilemma, I guess.
Another BB.
Hi, good evening. So I thank both the speakers to putting their points. I'll summarize. First of all, I in favor of osimertinib. So, but I do support few of the point of Ghansam sir. Yes, the most important point was the primary endpoint. Why not OS in a iterative setting? That is definitely debatable. I think
yes.
We don't have answer. In the previous trial also, DFS has been taken with a surrogate endpoint for all the adjuvant chemotherapy trial. But in 2020-23, I think OS should have been the primary endpoint. As far the toxicity goes, it's not a matter. We know this is the most safest TKI and we can manage that. But the basic question is that Ghansam sir wanted to put whether osimertinib now or at recurrence. That was the most important point of the whole adverse study. Cost is will remain same whether you use now or at recurrence. But the question is, if I can prevent more of relapse and improve the survival, why not in adjuvant setting? Regarding the adjuvant chemotherapy, if you see the 40% patient didn't receive chemotherapy in both the arm, not only osimertinib, also in the control arm, because 36% patient is a stage 1B where we do not give chemotherapy. Even if you see in the real world setting, not all patients receive adjuvant chemotherapy because they are not remain fit. Because as of now, it is only the cisplatin base that is recommended. And we see many of the patient is not fit for cisplatin based chemotherapy. So all patients other than stage 1B did receive adjuvant chemotherapy in the adverse study, followed by the randomization happened. They should have done one more MRI brain before the trial entry, but MRI brain PET CT and done most of the patient during the initial surgical resection, most common practice. So with the current DFS and the OS data, I am in favor of using osimertinib. Even for a stage 1B, I am more in favor of stage 2A, 2B, and 3A. Even in stage 1B, if you see the DFS hazard ratio for adjuvant chemotherapy trial, it was 0.94. But if you see the adjuvant osimertinib, it is 0.41. More than 50%, is less than 50%. So apart from stage 1B, I'm in favor of using adjuvant osimertinib in 2 to 3A, resected after completion of adjuvant chemotherapy. Another important question is why 3 years? I don't think we have an answer. We have taken the same from the imatinib trial, first 3 years. I'm sure in future, most of in 5 years. If you see the Kaplan-Meier curve, the curve started falling after 3 years more. The slant was more after 3 years. So that means when you stop osimertinib, maybe the patients start falling more. So you may need more How long, I do not know. So at least for a affordable patient, a resected patient, stage 2 to 3A, EGFR mutation positive, I will advocate for adjuvant osimertinib. And as the EGFR percentage goes, to best of my experience, the early stage disease, the EGFR rate is much lower in India. We have the multicenter data that EGFR is around 35 to 42% in India. I have been part of the LAURA study, that is osimertinib maintenance after CTRT. We failed to recruit single patient in 18 months. I have tested almost 10 patients, none become EGFR positive in adenocarcinoma. So what is, I believe, and as for the AstraZeneca data, the EGFR positivity rate in early stage 1 to stage 3 in India would be less than 20%. That's why we don't see that much of EGFR positive in a resected patient. So there are debates exist, and that debate will remain there. But my tendency is to in favor of osimertinib. That is my final.
One of the reason may be because we are not testing for any.
Sir, I am testing since 2018, each and every patient.
So
I have not seen that much.
Yeah.
So about this duration, there is a trial of new adjuvant osimertinib is going on for a couple of weeks, and they are monitoring CTCs. These are 20 odd patients, and which they found that the moment you stop the osimertinib, the CTC start appearing.
Right.
So maybe no, it is a prolonged duration, like a maintenance treatment is going to be the. I don't know.
In adjuvant study, they also have biomarker. I assume that sub population study will come out with the CTC and the ctDNA. How the ctDNA is falling on the adjuvant osimertinib. And we may select few patients. Yeah.
This is going to be a CML story where you want to stop after imagining 5 years.
Molecular remission, right?
Yes, yes, absolutely, absolutely. Thank you, sir. Thank you so much. Thank you, viewers, sir.
Thank you. Thank you.
Thank you, Ghanshyam sir,
Thank
and the
you.
organizers. Thank you. A lovely debate. I enjoyed the debate.
It was a thorough enjoyment, actually. Thank you. Thank you so much. Now, I would request Dr. Tathagat Das.
Romila, the prize, the winners.
Oh, yeah, sorry. I'm really sorry. I had kept it. Yeah, now with my bad. Sorry. Quiz, the second quiz results are for the first question, Dr. Y. Sushil Kumar. The second question winner is Bhavani Shankar Senapati. The third question winner is Dr. Dibanjan Kumar. The fourth is Dr. Swayam Prabha Sundar Ray. And fifth is Preetam Sarkar. Sir, I would request you to finally, the second day is coming to an end, so they wouldn't have a platform to complain, also transfer the money soon. So now I would request Dr. Tathagat to kindly please give the vote of thanks and conclude the third oncology updates.
Thank you, Romila.
Thank you.
I mean, it should be a general comment, actually, the vote of thanks. So thank you to all the speakers. Thank you, Romila. You really were quite strict on the time, which was good. And
no, my apologies. My humble apologies. I did not mean to offend anyone. Just that I was like,
you were meant to do that, so you did what you were supposed to do. So well done. I know how much work has been going on behind this scene. So Sambit, Anita, even Siddharth, so all of them, even they have managed to call me at like 2:30 in the night, probably sometime not recognizing the time gap. But no, so this is actually this is wonderful. This platform actually allows us to share ideas. So I do realize the normal tendency would be that practices in UK are very different to what we have in India. But I think that gradually those things will become a thing of the past. Things are changing very rapidly in India. And this kind of forum where we exchange ideas, people get together, it's wonderful. I really enjoyed both the days. Some of you might know. So I know Dr. Vishwas since 1991. So he was my senior in medical school 1 year. So he was kind of a mentor. So we were the bunch who used to cause all sort of trouble, and he was the kind of moral compass for us. And Ravi Shankar Patnaik is my roommate during undergraduate days. So our sort of association goes back a very long time. And I will be very happy to get others actually involved if that would be useful. If you find that kind of exchange of ideas, yes, things are never going to be same between different countries, different places, but we are, the world is shrinking. We all need to learn from each other. We need to learn from each other the good practices and the bad practices which we need to give up. So thank you very much. Thank you to all the speakers. Everyone was wonderful and I thoroughly enjoyed it. I'm sure everybody else has enjoyed. And the best thing is still have the Sunday to relax. So we have a long bank holiday weekend here, 4 days. So 2 days are gone. Thank you to Ghanshyam. So, so yes, I wish you all the best, and let's hope we carry on this kind of organizing this kind of events in the future. I would love to be there physically at some point, and it was really great. Thank you.
So thank you, Tathagat, so for those kind words, and special thanks to Dr. Ashok, who joined all the way, and a beautiful talk.
He has been there right from the beginning.
So Dr. Ashok, Tathagat, and Ravi, so all three international faculties of Indian taste. So we got that Indian taste. Wherever you go outside the country, so you try to find out kahan Indian khana milta hai. Usi tarah se. And thank you, Chandrakant, for being the program director. And unfortunately, Soumya could not join. And Romila has been a great help. So thank you. And the biggest support has been the back end, Sambit, Anita, Rudra, Sonali, Vivek. So many, Shravani. So they have been a great help. So we conclude the third oncology update with breast and lung. So June will be the best of ASCO, that is 28th, 29th, and 30th of June 2024 in Bhubaneswar at Vivanta. So whoever is listening, so they can make it possible. So I invite Dr. Ashok also, and Dr. Tathagat also, Ravi also, so they can come. And even 2025 and January 31st to February 2nd, we have a immuno-oncology where Dr. Allison, the Nobel laureate, 2 Nobel laureates have consented for, and they're coming after 30 years to India, and that to Bhubaneswar. So it will be all scientific feast in June 2024 and January, February 2025. So there is an open invitation from my side. So you are all welcome. So you'll have the hospitality. You'll have the great feast. So till we meet next, goodbye, take care, have a Good Friday weekend, long weekend, and we meet next. So we'll connect virtually and whenever possible physically. Thank you so much. Take care.
I think Dr. Ashok is wanting to speak.
No, I just wanted to say thank you very much. Very nice to be part of this, and it was a great session. Thank you.
Thank you.
So Anita, can you close?
Yeah.
So we'll be closing. Thank you. Thank you so much for your time. Thank you, ma'am, all of you.
You need to take rest. So Anita and Sambit. Thank you. Take care. Have a good Sunday.
Thank you, sir.
Thank you so much.